Okay, so good evening, good afternoon, hello everyone, and first of all, welcome to all of you for our this much awaited educational webinar from 360 Critical Care. And I would be very honest that the registrations for this webinar crossed 250 registrations, which is a huge number, and we have the attendees across the globe. So there are trainees, there are examinees from India, from Southeast Asia, from Middle East, from far away, I would say from Latin America also. So definitely this is a very motivating, and I would say we would be giving our best efforts to help you out in your exam preparation and also in your critical care day-to-day practice. Now, this session is a must-attend session for anyone facing the critical care practical exam, particularly, but we have also included the day-to-day clinical clues, or I would say clinical pearls, that would definitely help you out in managing the patients. So it's not for the exams, rather also straight from tomorrow also you can help out your patients. Now the session schedules, we have the esteemed faculties across the globe again. The first speaker is Dr. Sanant Kumar Das. He is also the course director as well as the 360 Critical Care Academy, the founder, I would say the director, and he is the consultant intensivist from Australia, a very dear friend of me. And the topic I have chosen, as well, I would say assigned to him, is again one of the most sought after domain in the practical exams and also in the MCQ based exams, in the theory exams. And this has been our observation for last 4 years since we started teaching for different various exams, critical care exams like EDIC 1, EDIC 2, the DM exam, DRNB exam, and also the fellowship exams. So that is ROTEM and TEG. And he would be definitely taking you to all the detailed analysis how you should approach if somebody is asking, or is there any report that has been shown to you in your practical exams. Welcome, Dr. Sanant.
Thank you, Tapas, for that kind introduction, and
And
good
with
evening.
this, I would also, Sanat, just like 1 minute, I would invite you for the talk. Now, the next speaker is Dr. Kyrillos Nassim, very bright, young, dynamic intensivist from Cairo, Egypt. And you won't believe he's so much academically driven that he has also many initiatives for the first time in the Middle East, and that is being appreciated by everyone who are preparing for various critical care exams. And it, I would say, demanding and I would say mark fetching in the practical exams. Welcome, Dr. Kirlos. Okay. Now the third speaker is Dr. Jitendra C, a very dear friend and our core faculty for the EDIC 2 exam preparatory course from Bangalore, India. And he would be talking about IABP, one of the most sought after and confusing, I would say. People know about it, but when they would be asked related to some of the troubleshooting, they normally are fumble in the exam. So that's why we have kept the third topic, which he will be talking in the second sequence. Now, the last but not the least, myself, Dr. Tapas Kumar Sahu, again the 360 Critical Care Online Academy, the director, and also I would be talking about ventilator graphics, very much mark fetching, and that would be concluding our session for today evening. Now, just two lines before I will be handing over to Dr. Sanant. What is 360 Critical Care Academy? We are one of the premier, globally trusted, and highly successful online and also on site teaching academy dedicated to excellence in critical care education. And the missions that we started with 4 years back is to deliver world class evidence based critical care education across continents. We determined to bridge the gap between theory, bedside practice, and again, finally, what we normally strive for, that is the exam excellence. We also strive to train clinicians to think like experts, act with precision, and again lead in their clinical practice with confidence. And the final objective of this initiative is to build a global learning community that is driven by collaboration, mentorship, and innovation. Now, this is something which we thought about and we framed this session. There is echo, I think, happening. Okay. So the idea is we have the comprehensive teaching program for all the critical exams and trainees, DRNB, DM, EDIC 1, EDIC 2, fellowship and on-site teaching. The second one, we try to provide education for the entry level trainees also, starting to JEET exam talk. And on big news, we are launching soon the 360 Critical Care Academy app, which would be dedicated exclusively for your day-to-day education purpose. And also we would be having all the resources, all the exam oriented teaching and resources, and also the live classes that would be definitely helpful in your like day-to-day training period. Last but not the least, recently we launched one book exclusively for the critical care practical examinees, that is top manual for the critical care exit exam, that has included the cases, the long cases, the short cases, the clinical examination, the OSCE, and we have unveiled this in our recently conducted Mumbai course. But yes, the final version for the mass use, we are expecting this to be in the next 3 months, where you all will be getting if you wish to have one. So with this, we are now into the first class. We named it as, again, from our 360 critical care, we thought about naming this as 360-degree concept. And the concept is to clear all your doubts from the grassroots level. And we will be trying to provide you the basic concept and again to the advanced level exam. For today, webinar is by Dr. Sanand Kumar Das. So I'm stopping to share here. And thank you for again joining. Definitely we'll have a very great session. Already 110 plus candidates have joined. Dr. Sanand, now the show is all yours.
Yes, the first. Uh, Again, give me 2 seconds, Tapas. I have some issue with sharing. Uh, just 1 second. Yep, got it. All right.
In the meantime, we are expecting the questions and answers for your the thought process, how you will be tackling at the bedside and also in the exams, some of the clinical pearls that you need to remember, because there are examinees who have their practical exams just 5 days after. So these 4 domains would definitely be asked to you, and be assured that if you go through this webinar, you will be answering almost 90% of the questions those would be asked to you in the exam. So in the meantime, Dr. Sanant gets back to us with the power packed the ROTEM
Can
and
you,
TEG, Dr.
Tapas,
Kirlos
can you
and
see my
Dr.
screen?
Yeah, yes, it's done. Yeah, perfect.
All right, okay.
You can
So
start
after
now.
a lot of struggle, I managed to. Okay. Good evening, everyone. So, as the first was saying, this is a very important topic, and exactly a bit confusing also. So, in the exam, the expectation is that they will be giving you a picture of a ROTEM, and they will be asking you about your interpretation or your management plan. So in this session for next half an hour, we'll be talking about ROTEM. So I'll just go ahead a little bit of basics of ROTEM so that you guys will be acquainted with what does it mean, and if you are given a scenario, how to interpret it. So ROTEM stands for rotational thromboelastometry. It is a point of care therapy directed information on coagulation. The aim for ROTEM is to optimize the transfusion of blood products, and also in clinical studies it has shown that it has reduced the transfusion requirement and transfusion associated complication. Now, um, real time and graphical, that's what you get in a ROTEM. It gives you an idea about the clot, that is the time of formation of clot, the strength of the clot, and how does it gets breakdown or broken down. So it's not only about one phase of the coagulation, it is a holistic representation of the coagulation at different phases at different times. So how does it is carried out usually? So the whole blood is taken and it's put into a cuvette with calcium in it, and a pin, which is you can see here, is suspended into that cuvette and it starts to spin. The pin rotates gently back and forth in the liquid blood. Initially there is no resistance, but as the blood starts to clot, there is an increased resistance there in the cuvette, and that modifies the movement of the pin, giving you a particular shape of the curve, which is we call it as a temogram or the ROTEM curve. Now there are different curves that we look at based on the reagent used in the cuvette. Usually there are 4 or 5 specific curves that is represented in that figure. So first of all, the first one is called as the FIFTEM, which is fibrinogen oriented. So in FIFTEM, you get more idea about the fibrinogen as the factor of coagulation. The second is called as the XTEM. It represents the extrinsic pathway of the coagulation. The third one is a INTEM, which represents the intrinsic path of the coagulation. Um, the fourth one is called as EPTEM, which is representative of a situation where aprotonin is added into the blood to enhance or to decrease the clot fibrinolysis. And the last one is a heptem, which looks at the effect of heparin by putting heparinase into the system so that it breaks down the heparin in the blood. And whatever you see is the representation of the current coagulation status of the blood. So there are 5 channels, we say. First of one is the FIBTEM or fibrinogen oriented channel, XTEM or extrinsic pathway, INTEM is intrinsic pathway, EPTEM is more looking at the fibrinolysis component of that. You add a aprotonin into the blood. And the fifth one is the heptem or heparin channel, where you neutralize the effect of heparin by putting heparinase into the blood. So 5 channels, okay. Um, Now, a little bit of theory that you need to understand, because the clot formation or the whole process of coagulation is divided into majorly 3 phenomena. One is a initiation, amplification, and propagation. Between amplification and propagation, the phase of fibrin formation happens. So the initiation happens with the tissue factor, which is the main starting point for the coagulation, or it is a procoagulant factor. Tissue factor exposed to the blood causes factor 7 activation, which produce small amount of thrombin. This is followed by the amplification where platelets and cofactors are activated, and hence other factors get also activated, and there is platelet aggregation, and there is propagation of the clot afterwards with a common pathway. So the theoretical part of the coagulation is usually we read as two different pathways, but it's not as simple as in this. The in vivo mechanism is pretty complicated, but for our easy understanding, we think it is an intrinsic pathway and there is an extrinsic pathway which converge together for a common pathway. In the common pathway, sorry, in the common pathway, you have the factors 2, 5, and 10. In the intrinsic pathway, you have factor 8, 9, 11, and 12. And in extrinsic pathway, you have majority factor 7. So the common pathway leads to formation of fibrinogen and then fibrin clot. So this is the usual concept of coagulation that you guys know. Now the most important factor in the whole of the coagulation system is the fibrinogen. It is the most prevalent clotting factor and the final clotting factor in the common pathway, as we discussed. Interestingly, fibrinogen is consumed the fastest when the clot is activated. So fibrinogen is the first factor to fall critically low, uh, becomes critically low in a patient who is bleeding or hemorrhaging, because the body uses up the fibrinogen, and the first factor that decreases in such a situation is your fibrinogen. The fibrinogen levels are usually higher in pregnancy because pregnancy leads to delivery of the baby and there is high chance of bleeding. So as a preventive mechanism from the nature, we have a higher fibrinogen. This is the only coagulation factor which is higher in pregnancy. Now, early fibrinogen replacement assists rapid correction of coagulopathy and reduces transfusion of other blood products. This has been proven with multiple clinical trials also. Sometimes they ask you what are the sources of fibrinogen in clinical practice. So usually there are three important sources: fibrinogen concentrate, the highest amount of fibrinogen you find there, followed by cryoprecipitate, a little bit low, and if it is a aferritic cryoprecipitate, the concentration is slightly high. The least you find in a fresh frozen plasma. Now, the major coagulation determinants in major hemorrhage are the coagulation factor for sure, but there are other things that determine the patients whether they are bleeding, not bleeding, whether they will continue to bleed or not. Apart from the coagulation factor, there are other factors are very, very important which cannot be measured by your ROTEM. So you need to know what are the things that cannot be measured by this point of care coagulation test. First of all, hypothermia is a major barrier for coagulation. If the patient is hypothermic, then the coagulation whole cycle gets delayed and the patient continue to bleed. So optimization of the temperature. Unfortunately, the ROTEM system measures all the coagulation factor, and studies happen at room temperature. The patient's blood may not be at room temperature, so it may not represent the exact problem that is going on if the patient is hypothermic. Second is hypocalcemia. In this test, calcium is added to the sample, thus correcting for platelets for patients with hypocalcemia. So you cannot evaluate a patient with hypocalcemia that the bleeding disorder is because of hypocalcemia. That's the problem of ROTEM, because calcium is added into the blood and it is corrected. So you will not be able to know whether hypocalcemia is one of the cause for bleeding for that patient. It is not useful if the patient is on therapeutic, or it is not useful for monitoring of therapeutic efficacy of anticoagulants such as heparin, low molecular weight heparin, pentasaccharides, nanoparoid, or anticoagulants which have direct thrombin inhibitor or the NOACs. It is not useful because it is not a quantitative value saying that um, the patient is more coagulopathic or less coagulopathic if they are on anticoagulants. If the patient is on a platelet inhibitor, they will not tell you with ROTEM. So ROTEM is useless if the patient has ongoing platelet inhibitors such as clopidogrel, aspirin, or a GP2B3A inhibitor. Patients with uremia, patients with von Willebrand's disease, you cannot find an abnormality with ROTEM. Again, platelet dysfunction, functional issue with the platelet may not be appreciable with ROTEM. So these are the drawbacks or limitation of ROTEM. And also patients who are acidemic, also in those cases acidemia is one of the varicose triad thing that prevents coagulation to happen. So this system cannot determine whether the patient has acidemia causing coagulation issues. So these are the limiting factors or limitation of ROTEM or point of care coagulation testing. So you need to know about this. This is a usually asked question in the exam. They will be asking what are the things or what are the coagulation abnormality that a ROTEM cannot detect for you. Now there are two types of ROTEM where one checks with or without heparin. So if the patient, if you have cardiothoracic working in a cardiothoracic unit, so you may have a machine which uses a cartridge for heparin or has an additional channel of heptem. It is called as the complete plus hep channel. So this is a different channel. So there are two different cartridge for two different result to find. So the first one is usual Fiptem, Extem, Intem, and Eptem. Instead of Eptem, in a patient who is heparinized, you may need this channel. So it is called as the complete plus hep. So Fiptem, Extem, Intem, and Heptem. So you look at heparin effect in this type of cartridge. The bottom one, this type of cartridge, but the top one does not give you a heparin effect. So if the patient is on heparin or is being anticoagulated with heparin, then you have to choose this cartridge and use this. And if the patient is not on heparin, then you have to use this cartridge or use this interpretation. So this is all technical things. So whatever cartridge or what machine you use, depending on that, it varies. Now going into a detail of the ROTEM. So first of all, I told you about a temogram or a fraction or one fraction of the diagram is called as the extem. It represents the extrinsic pathway. It contains the tissue factor and other factors for coagulation. It assesses the combined effect of fibrinogen and platelet. Just be careful what I'm talking about. This is very important. The extem looks at both platelet and fibrinogen, right? Both platelet and fibrinogen. It's not only one thing, okay? Abnormal clotting times are used to determine if there is a clotting factor administration requirement. So it also looks at clotting factor deficiency. So fibrinogen, platelets, and clotting factor. Three things can be seen here, okay? The next one is FIPTEM or fibrinogen channel. So the FIPTEM channel contains the same reagent as XTEM, but in addition to that, it inhibits the platelets. So the platelet effects are neutralized here, and whatever you see in this channel is because of fibrinogen. So FIPTEM looks at the effect of fibrinogen. So if the FIPTEM channel is within normal range, then you need to look at the difference between FIPTEM and the XTEM, because as I said, the XTEM measures both fibrinogen and platelet. The FIPTEM measures only the platelet effect. So if this is normal, the FIPTEM is normal, where the platelet function is neutralized, and you find abnormal XTEM here, that means the fibrinogen is normal, but the abnormality is because of the platelet. Do I make sense? So in the FIPTEM channel, whatever you see is because of fibrinogen problem. Then platelets are totally neutralized. So there is no platelet effect that can be seen. Whatever abnormality you find is fibrinogen issue. If this is normal and the extem is abnormal, that means fibrinogen is normal in the blood. The abnormality in the extem is because of the platelet. So that's how you delineate. If the extem is abnormal but the fibtem is normal, then the problem is because of platelet. All right. There's a question in the chat box. Can you go to the previous slide, extem? Yes, we can. Close. Sorry. Yeah. So explaining again, this is the extem channel. So it looks at both the effect of fibrinogen and platelet. So whatever you see here is the combined effect of fibrinogen and platelet. In the FIB10, whatever you see is because of fibrinogen. So if the patient has a normal fibrinogen and an abnormal platelet, then your extem channel will be abnormal. If the patient has normal platelet but abnormal fibrinogen, then both extem and FIB10 channel will be abnormal, because this channel looks at only fibrinogen and this channel looks at both fibrinogen and platelet. All right. INTEM, the INTEM channel assesses the intrinsic pathway. So abnormal clotting time in this channel are used to detect heparin effect, like APTT, similar type of thing. So if there is abnormality here, it is because of heparin effect, or it can also used to be look at protamine excess. It may also, because anything that is abnormal, that causes a abnormal intrinsic pathway it will be shown in this channel. So whether it is heparin, whether it is protamine excess, whether it is clotting factor deficiency, whether it is a fibrin polymerization disorder, or any other anticoagulant affecting the intrinsic pathway, you will find a abnormal intent. Okay, intrinsic pathway problem, right? Now, why I'm saying protamine excess and heparin effect? I discussed about that, or I asked a question in the group earlier about this. We will take it later. The last channel is the heptem. So as I said earlier, what happens is in heptem we neutralize the heparin. So whatever effect of heparin is totally taken care of. And whatever you see is totally because of other things than heparin. Okay. So suppose somebody is on heparin, then the intem channel, the clotting time will be very prolonged because of heparin effect. But that effect will be corrected in heptem, because you have neutralized the heparin. You have totally discarded the heparin effect. So whatever is there in heptem is not because of heparin. It is because of something else, right? So if you have a prolonged clotting time in intem which gets corrected in heptem, that means it is heparin effect. But if you have a prolonged clotting time in intem and also heptem, it is not because of heparin, it is because of something else, some other inhibitors. Okay, so that's what you need to understand. So the heptem channel contains heparinase, it destroys the heparin. So this channel demonstrates heparin effect by an improved clotting time when compared to the intem channel. So in intem you will find a heparin effect. In heptem you will not find a heparin effect. If this occurs, then protamine is indicated. Like if the clotting time is prolonged here in the intem and it gets corrected in the heptem, that means there is a heparin excess and you need to neutralize the heparin with the protamine. So you give protamine to that. If extensity, so remember extem, the channel here, if the extensity is normal, that means your platelet and possibly the fibrinogen are normal, but the intem and heptemcity are prolonged. So the intensity is prolonged, the heptemcity is prolonged, but the extensity is normal. That means the patient has protamine excess. Okay. So normal city in extem, abnormal in intem, and heptem means you have protem in excess. So the question that I asked in the group earlier, how do you determine a protem in excess? So for protem in excess, what will happen is your clotting time is normal in the extem, but it's abnormal in both intem and heptem. Now, how is it different from other inhibitors? So if there is other inhibitors present except heparin, the clotting time will be prolonged in all the channels 1, 2, and 3. All the three will be prolonged. But if it is protem in excess, then both intem and heptem are prolonged with a normal extem. Okay. Hope that makes sense. We'll go to some examples and that will make it a bit clearer. Now the parts of a ROTEM. So initially you looked at the clotting time or CT. This green part is the CT or clotting time in seconds. So it represents the initiation phase, that is the time from start of measurement until initiation of clotting. So you started measurement here, this is 0 time, and the length of that is the clotting time. If it is more, that means the clotting time is more. If it is less, the clotting time is less. So it represents the time for clot initiation, thrombin formation, and startup clot polymerization. So prolonged CT causes the causes for prolonged CTs are clotting factor deficiency, heparin effect. We talked about that, and you have to see how do you know which is because of what. So heparin effect will be corrected in heptem, but if it is due to any clotting factor deficiency, it will be not corrected in the heptem. We look at alpha angle. So alpha angle represents your what do you call clot initiation or clot strength. The higher the angle, the better it is. The lower the angle, the worse it is. Okay. Clot formation time. So clot formation time is clot formation time in second, which represents the pink part. So when you have, this is a time initiation of clotting like 2 millimeter, where the height is 2 millimeter until the clot formness goes to 20 millimeters. So that part is the clot formation time from 2 millimeter to 20 millimeter there. So that duration is called as the CFT or clot formation time. Again, it represents the fibrin polymerization, stabilization of clot with platelet in factor 13. If there is a deficiency, then the CFT will be prolonged. Usually, it's not clinically important. We don't look at the CFT usually. Next, maximum clot formness. This represents a millimeter height. So it represents how strong or how firm is the clot, and increasing stabilization of clot by polymerization of fibrin and platelets and factor 13. So that MCF will be low if you have deficiency of fibrin or factor 13. Okay. Now, important thing to look for is the A5. So it represents the clot firmness at 5 minutes post clotting. So if you start clotting here, 5 minutes post clotting, what is the clot firmness? What is the height? All right. So that represents the A5. This is an important number. So A5 we look at FIP10. So A5 represents the clot initiation or initial firmness of the clot. Okay. I'll go to in detail in subsequent slide. Then you look for maximum lysis. So percentage reduction in clot formation at a particular time. We usually look at 1 hour or 45 minutes, right? So reduction in clot formness after maximum clot formation. This is the maximum clot formation, and we look at a particular time. How much is the clot lysis? Okay. Stability of the clot. If maximum lysis is less than 5% at the measurement time, this is normal. But if the ml is more than 5% at or within 1 hour, then it is a sign of fibrinolysis. Massive fibrinolysis can result in a long CT or clot formation time or a small or absent disappearing A5 or A10 in all channels except eptem, because in eptem you give eprotonin, which neutralizes the fibrinolysis. So that's how you know. So in EPTEM, if the times are getting corrected, but rest of the places it is abnormal, then it is a fibrinolysis issue. Now for prerequisite, the thing that you remember clinically is you don't treat the graph, you treat the patient. If the patient is not bleeding, you don't have to do a ROTEM and you don't have to treat it. But first and foremost thing is to optimize the basic needs for coagulation that we talked about, because ROTEM is very dependent on these, and it is measured at a normal condition where the temperature is body temperature, pH is normal, calcium is normal, and hemoglobin is normal. So you have to ensure that the patient is normothermic, pH is more than 7.2, normal ionized calcium, and preferably hemoglobin of 70. And then only you send the sample for a ROTEM, because all these are determining factor of coagulation and will affect the result of coagulation, but you will not be able to assess them through ROTEM. Okay, now interpretation. So first step, what you do is to check for a heparin excess. If the patient is on heparin infusion or the patient is on a CP bypass, suppose in between CP bypass the anesthetist come with a sample of blood to see in those cases. So what happens is in heparin excess you will have a in-tem clotting time more than 205, but this gets corrected in heptem. So the clotting time will be higher in in-tem, but it gets corrected in heptem. What does that mean? Is heparin excess. So what will you do is to give protamine just to reverse it, right? The second step is you assess always fibrinogen. As I said, this is the most important stage, and fibrinogen is the most important and earliest factor that gets depleted during bleeding. So you have to first assess the fibrinogen. Depending on what machine you are using and what setup you are in, there is a particular algorithm that we go. But in my setting where we look at FIPTEM A5 or at 5 minutes, what's the FIPTEM height? If it is less than 9 millimeter, that means the patient is deficient in fibrinogen. As I said, FIPTEM looks at the fibrinogen. So that's the first thing you look for. If it is less than 9 millimeter, that means there is a fibrinogen deficiency. You need to give cryoprecipitate or fibrinogen concentrate to treat. So this is the first step you have to do. First step is the assessment of fibrinogen, or first, if the patient is on heparin, you have to rule it out. And the next step is to assessment of the fibrinogen. Then the next step is looking at platelet function. As I said, platelet function is assessed in two different channels. One is a FIPTEM, the other one is a XTEM. But in FIPTEM, we neutralize the platelet and we look at only fibrinogen effect. If the clotting time is high both in FIPTEM and XTEM, you know that it may be due to fibrinogen or due to platelet or both. But if the FIPTEM clotting time is if the FIPTEM is normal and XTEM is abnormal, that means there is a problem of platelet. Okay, so that's what it is. FIPTEM A5 is normal, more than 9, but the XTEM A5 is less than 35, which is abnormal, or FIPTEM is low and the XTEM is low. Both are low, or FIPTEM is normal but the XTEM are low. That means there is a platelet deficiency. Okay, you need platelet transfusion. Next step is to look for other factors. Okay, factor deficiency. But the prerequisite is first you have to correct the fibrinogen. If you don't look for fibrinogen and correct it, then most of the channels will be abnormal and you will not be able to find the real reason for that. So you have to first look for the FIPTEM channel, correct the fibrinogen, and then go next step. Okay. So the fourth step, as I said, is to assess the factors. In this case, the FIPTEM the FIPTEM A5 will be more than 9, that is normal, and the XTEM CT is more than 90, which is abnormal. Okay, you have corrected the fibrinogen, but still the extem CT is still prolonged. That means your platelet is corrected, your your fibrinogen corrected, but still you have a coagulopathy, which is because of the coagulation factors. So you give FFPs or prothrombinics. The last thing that you look for is SS fibrinolysis. Like if straight away, if the FIB time is more than 600 seconds, then this is a massive early fibrinolysis. It is happening in the early stages. So you have to give tranexamic acid, or in the curve, if the maximal clot lysis is more than 5%, then you suspect it's a fibrinolysis. It may be a bit confusing talking about this, but people who have used it, it will be very easy to look for, right? These are all numbers that you get in the report. When I go to the example, it will be more easier. Okay, now let's start. I need this to be a little bit interactive, and people need to answer, otherwise it will be very monotonous and I cannot gauge how people are, what they get out of it. Okay, so that's the first example. What do you see? Can you take us quickly? So we have 10 examples. We'll go quickly. All right, someone, last slide, please. All right. I'm not going to discuss if nobody is going to answer. Abnormal 15, which is not abnormal, as you can see. A5 is normal, 15, it's not abnormal. Um, yes, fibrinogen deficient. Sorry. Okay. Fibrinogen deficiency, protein excess, abnormal 15, abnormal extem CT need. Yep. DOACs. You cannot assess the effect of DOAC. CT prolonged, normal 15, fibrinogen deficiency, normal. Okay. Let's do this step by step, all right? First one. So 15. So as I said, 15 shows the contribution of the fibrinogen. Platelets are neutralized in this channel. We discussed about that. Sorry. So in this case, the fibrinogen or 15 A5 is normal. It's 15. So that's normal. Okay. So there's no issue with the fibrinogen here. Next channel that we see is the extem. So what do we know about extem? Extem looks at platelet and clotting factor, including fibrinogen. Okay. Now in this case, the CT is prolonged to 110, indicates possible clotting factor deficiency because the fibrinogen is normal here, and either it is a platelet issue or a clotting factor issue. Now, platelet contribution is the difference in A5 between extem and 15. So look at extem is A5 is 36 or 35, and here is 15, and the difference is more than 20, which is pretty good. Okay, so the extra effect of platelet in excess of fibrinogen is from 15 to 36, which is 20. Okay, which is acceptable. So probably the platelet functions are good. So no issues with platelet. Now go to intem. What happens with intem is the clotting time is prolonged. So this means in the absence of heparin, because this patient probably is not heparinized, this channel is not necessary to guide transfusion product. But when you look at EPTEM, oops, sorry, it shows the clot stability, but compare the extem with the eptem and maximum clot lysis determining the fibrinolysis. So here the clot lysis is 0%, so no fibrinolysis happening. So eptem is used for fibrinolysis. The major effect here is either it is because of a problem of platelet which we think less likely, or it is a problem of coagulation factor. Okay, because the extem and the intem, both the clotting, the CT is prolonged. So it is an issue with the coagulation factor. So in that case, how do you treat it? You give fresh frozen plasma or prothrombin. So basically, how you evaluate is, first step, fibrinogen 15, which is normal. A5, we look at the A5 normal, so it is not a fibrinogen issue. Go to extem, the CT is prolonged. The CT is prolonged can be due to either fibrinogen or clotting factor or platelet, but we know that the fibrinogen is normal, so it is a problem with clotting factor or platelet. Now, because the A515 here and the A5 is 36 here, there is a quite a good amount of contribution from the platelet. So probably platelet is not the problem. It is possibly the clotting factor. The second or third step that you look for is the intem. The clotting time both in intem and extem are prolonged. That means it is a coagulation factor issue, which you will treat with FFP. The aptem is used to look for clot lysis. If there is no clot lysis, then that's what is your diagnosis. The patient needs FFPs. Okay. Now, second one, let's talk about this. What's happening here? Can you take us quickly? Okay. Somebody says, Venkata Ganesh says fibrinogen deficiency, fibrinogen deficiency, fibrinogen deficiency. A5 is less. Yes. I think now it makes sense. I hope people who are answering can see. Now, the A5 here is 7, which is marginal, like 5 to 20. So it is less, probably less, because I showed you that graph earlier, the table or the arrow mark, that we look at a A5 of around 7 as the minimum, or 8 is the minimum. If it is 7, then we are in trouble. Okay. So you have a 15, which is less than 8 or 7. That means there is a problem with fibrinogen. We know that already. Okay. Next step is extem. Now it is very hard to see the effect here because the fibrinogen is already deranged. So interpreting anything in extem, intem or aptem will be difficult because you have to correct the fibrinogen first and then look for the platelet effect. Okay. So in this case, what will you do is to transfuse fibrinogen to the patient. Okay. The only extra information that you can get in aptem is the maximum lysis, but it is 1%. So anything more than 5% is abnormal. 1%, so there is no increased fibrinolysis. So how will you treat it? You will supplement the fibrinogen here. Okay. Because with other channels, will not be able to interpret anything as long as you have a fibrinogen deficiency. Okay, so fibrinogen concentrate will give or cryoprecipitate, depending on that. You can supplement pool of platelet because you are not sure whether it is because of platelet and fibrinogen or just fibrinogen, just to make things a bit more problematic. So you can see this A5 is 7 and in the extem A5 is 17. So rise in the A5 is only 10, which may also be an indicator of platelet deficiency. So you need around 20 increase from that to there. A5 should increase from 7 to 27 to say that the platelets are adequate, and it's only fibrinogen because the increase is around 10, so it's not too high. But again, this is just a rough estimate. It's very hard to see how much platelet are contributing to this abnormality, as long as you have to correct the fibrinogen first. But again, we sometimes look at the difference. Difference is not too high. That means there is a contribution to platelets also. Okay. This one, any takers? So 35-year-old woman, gravida 5, para 4, suffers at PPH with hemodynamic instability, taken to theater for intervention. What products will you advise? So A5 is 10 here. Usually in pregnant patient, we want an A5 around 11. So if it is 10, probably it is a fibrinogen deficiency. In XTEM, the A5 is pretty robust. Can you see 45? So 10 goes to 45. So good platelet function. But the problem is with fibrinogen. So what will you do again? Transfuse fibrinogen for obstetric bleeding. So just keep in mind the obstetric cutoff for A5 in most of the centers are more. So you need a higher A5 for obstetric bleeding. So at least by 2. So in normal patient who are bleeding, we look for A5 of 7 or more. But for obstetric, it is 9 or 11. Okay, so slightly higher. Okay, right. Let's go to the next one. Any takers for this? The clotting time is 4059 in the 15 and you don't have anything in the 15, just like a straight line again. So this is the usual thing that you see, all right? So it is a fibrinogen deficiency again. So I'm showing a lot of fibrinogen deficiency because it is very common, okay? So the way you can find a fibrinogen deficiency, one is A5 will be totally gone. There is no A5. The other one will be a clotting time high, and this can also be present if there is a hyperfibrinolysis. So there is no fibrinogen and the clotting time is very deranged, and you will get a maximal clot lysis more than 5% here. But this one doesn't have a ml of 5% or more. So this is probably only fibrinogen deficiency. Okay, got it? Early fibrinolysis, you can see that. So you again supplement fibrinogen in this case. What is this one? Quick, quick. What is this one? This one. Somebody has pointed. What does that mean? 100%. So again, fibrinolysis. How will you treat is any answer? How will you treat this? Tranexamic acid. Right. Correct. Okay. Now next. 60-year-old woman who was admitted with subarachnoid hemorrhage is less responsive after sudden gush of blood into the EVD. How would you proceed? That's her ROTEM interpreted. Again, clotting time. These are all practical cases, so very, very, very high. What's happening with the ML here? 99%, 6% in EPTEM. Okay. Again, fibrinolysis, tranexamic acid. What's happening with this one? Can you take us quickly? So 15 A5 is normal. Okay, what does it say? Factor 7. Okay, factor 7 deficiency. I cannot make out what is factor 7 deficiency, right? We talked about this. Now in TEM, what is happening? The clotting time is abnormal. It gets corrected in HEPTEM. Okay, what does that mean is the patient has heparin on board, right? The INTEM, which is completely abnormal, gets corrected in HEPTEM. That means there is a heparin effect. So you give ROTEM to this patient. Okay. This one 56-year-old man post reduced sternotomy for AVR and cabbage. Drain output is 400 ml in first hour. What are the next steps in patient care? Okay, what's happening here? Again, just look at the star one. So in lysis is 9%. So again, there is increased lysis. Though it looks fat and wide, but you have a clot lysis of 9% and the patient is bleeding. So what will you do? Tranexamic acid. All right. Okay. This one, we talked about this already. So in TEM, the clotting time is 1500, which is abnormal. In HEPTEM, it gets corrected 138. So what is this? Heparin effect. Okay. So what will you do? Give protamine. Very common in the exam. Okay. What is this one? This is important one. Now see this bottom line here. I'll just point out what is there. So in the INTEM, the clotting time is 268. In the HEPTEM, the clotting time is 369. Okay. Both are prolonged. And in the EXTEM, the clotting time is normal. We talked about this combination already. What is this? Yes, it's protamine excess. So what will happen? You'll have a prolonged time in INTEM and HEPTEM. EXTEM is normal. So you have given protamine in excess amount. So protamine in excess amount is a anticoagulant. Okay. So in excessive protamine use, you will have INTEM and HEPTEM prolonged but normal EXTEM. Okay. All right. I think this was the last example, I believe. Yep. Thank you. Thanks a lot for your patient hearing. And if you have any questions, I'm happy to answer. Otherwise, I will hand over to Tapas, who will be talking about the next session or whoever the speaker is. Thank you. What
Hello.
about other numbers? Uh, Previous two slides answers. We discussed about that already, didn't we? So this is the question. You mean this one? So this is the heparin excess because you have your clotting time is high in the INTEM, that gets better in the HEPTEM. So that means if you put heparinase, the clotting time gets normal. That means there is heparin excess. So that's the one, and the previous one before that is this. So this looks normal except for the plot lysis, maximum lysis ml. So 9%, which is more than 5%. That means the patient has ongoing fibrinolysis. You give tranexamic acid. Okay. Hope that makes sense.
Yeah, Dr. Hamid, we will be sharing the recorded session soon after editing. So just bear with us for the editing purpose. But please attend it live and hopefully this would be more useful to you.
Somebody has told Tapas that in my EDIC exam I could not see any number. I just saw pick and guess what happening. Okay, so you need to know the what do you call the structure of the champagne glass. Okay, you just Google on the you can Google it and see ROTEM champagne glass format. So there are two or three things that you need to know. We talked about that already. So this is the usual. Even if you don't see the numbers, it's pretty self-explanatory. Like I'll show you. This one is fibrinolysis. As you can see, a flat line in the 15. So you don't have to have anything there. Okay. Even if the no number, you can see this is fibrinolysis or fibrin deficiency. This is again late fibrinolysis. You can see this type of what do you call picture. This is late fibrinolysis. Then this one, the first one here again a straight line. Same fibrin deficiency or fibrinolysis or early fibrinolysis. Um, this one again, you have a narrow FibTem, so that means there is fibrin deficiency. So you need to know what channel you need to see and what are the abnormalities. Just Google some pictures. You'll be well acquainted with that. Sometimes you may not find the numbers.
I have that. If you like, I can share. Just
Yeah.
1 second. Yeah, I will be showing you. Is it visible?
Not yet. Yes, now you can see it.
Yes. Yeah, Sanant, you can go through this one and explain if the candidates expect any answers. But I think after your so elaborate discussion, the candidates would be now more clear about the structure, how to approach, and also this is the different champagne bottle, the glass, and you can how you can guess what is happening. So this is the common ROTEM patterns. This is brandy snifter. This is the
That's the
normal
normal
format.
one.
Yeah.
Then
Then the
if you have factor deficiency, your clotting time will be prolonged, as you can see here, before it goes up. So this is the clotting time is prolonged, the stem of the champagne glass. Fibrinogen deficiency, in that case, your A5. So A5 is low, 5 minutes, A5 will be low. Okay. So in that case, you have to give fibrinogen again. Thrombocytopenia, again, I mean, I told you about, so this is going parallel, it doesn't go up like this. Can you see how it goes up in the wine glass, in the brandy? It goes up in a tangent with a good alpha angle. If the alpha angle is not good and it goes parallel, then it is a thrombocytopenia. Okay. Fibrinolysis, as you can see, it is narrowing down. So inverted Martini glass. So it's easy to remember if you can see these curves, but practically you need to have numbers also. I don't know what will you get in EDIC exam, but you may get it without the numbers, and they can give you that also.
okay, perfect. Thank you, Dr. Sanant, for taking your time at I think 11:30 or 12 midnight now. There, 12:30, I think. Okay. So if you have any doubts, you can post it in the chat box, or also you can post in our various the social media as the WhatsApp groups, and we will be definitely getting back to you with more resources. So with this, I would be now inviting Dr. Jitendra C from Apollo Hospital, Bangalore, dear friend and colleague, and he will be talking about again one more important domain, so just like related to the heart, and that is intra-aortic balloon pump. Over to you, Dr. Jitendra.
Thanks, Professor, and good evening, everyone. So after this elaborate discussion on one of the hot topics in CBS questions, that is ROTEM. So now we'll go into another hot topic. You definitely will get a question on IABP. I mean, few exams, there has been a question on IABP. So that is why we'll be going in a little bit detail on this, and mainly we'll be trying to show you to this kind of questions you can expect in the exams in this particular topic. And I'll be and we'll make it a little interactive so that it will be. I mean, we'll come to know where we stand before the exams. So is my slides visible?
Yes, Dr. Jitendra, yes.
Okay, sir. And I'm audible.
Yeah, you are audible, but I think there is some echo happening because two of our the attendees have written like the voice is not clear. Though I can hear you, but something is happening. So you can uh,
Just check.
yeah, your voice is audible, that's for sure. But yes, this is not very clear. Agree.
Okay. Now any better, sir?
It's better. It is audible. I think you should continue.
Right. So another factor you can see yes is about IABP. So though you see it has been downgraded, it's still one of the most common mechanical circulatory device which you use and which have been used in multiple places. It is the most commonest one. So whatever be the level of evidence and recommendation. So today we'll be discussing and this will be our agenda. So we'll discuss about hardware and the monitor. Because sometimes you get questions where they display the monitor screen and ask you what is the finding there. Next, we'll discuss about the waveforms, which is the most commonest and commonly asked questions, and little about the physiology. So, because if you understand the physiology, it's easy to answer any abnormalities you see on the waveform. And then indications, contraindications, little about the complications. And as said, the errors in timing. This is the most common question which is asked. Little about the evidence, because not only that, you can be asked about
Dr.
IABP.
Jitendra, Dr. Jitendra, if you can come to little bit nearer to the laptop maybe, or the candidates are having slight difficulty that the voice is not clear. It is audible, but yes, if you can do something, mm, or maybe you can just go little bit slow because the
Better
echo
now,
is
sir?
actually, yeah, I think this is better. Yeah, yeah,
Okay.
yeah, perfect.
Okay, so again, I'll repeat the same. So that's what we'll discuss little about the hardware and monitor. So because as I told you, monitor images will be shown in the exam to pick up what is the abnormality seen. So little about that. Then the waveforms and physiology. So how you get those waveforms? What is the physiology behind it? Then the indications and contraindications. Some complications which are common because I mean, it's a procedure being done. So any procedure, as you know, EDK exams, you will definitely be asked about the complications associated with it. And here we have waveforms, and we know there are errors in timing. So that is what is a hot topic in IABP. So errors in timing, you'll have to identify the error in timing and what you do and how you recognized it. That is what they'll be expecting in your exams. Next, little about the evidence because now it is evidence-based medicine, and any question they ask, they you can expect them to ask about evidence. And next, I'll discuss the most commonly asked questions also. So that is what is the agenda for today's discussion. So, and as I said, we'll keep it interactive because otherwise it'll get very boring. And when you are interacting only, you'll come to know so where you stand. So what are your mistakes you do, and there's no exam. So you can definitely do some mistakes here so that you will not be repeating it in your subsequent exams. Okay. So this is the console how it looks. So I'll not go into details of this. This is how it looks on the back of it. You have a helium tank there. You have some fibers running there. So this is how it looks. And you have a console and you have a display there. And next to the display, you have a interface where you'll be using multiple buttons to make some adjustments in your settings. Okay, so this is how it is placed in a 3D image. So this is how your IABP balloon, the tip of the IABP balloon. And where should it be placed? Anyone who wants to take the answer? Where should the IABP balloon be placed? What is the optimal position for the IABP balloon? Anyways, I'll be discussing it. Okay. So this is how it is placed. So it will be just 2 to 3 centimeter distal to the offset of your left subclavian artery. That is where it is should be positioned. And I'll be discussing little later. So this is how it looks in the real time. So this is the arch of aorta, descending aorta where your balloon is.
Dr. Jitendra, if you can make it
Yes,
in the
sir.
Zoom, like your
Oh, sorry,
slide
sir.
is, yeah, yeah,
Yeah,
yeah.
sorry, sir. Okay, yeah, now it is better. So this is the console's picture, the display picture. So the top one is the monitor of your console. So the top green line is your ECG, and you get the heart rate from the ECG. Next, you have your arterial waveform, and next below that arterial waveform, the one in yellow is your arterial waveform. It can be in different colors, that doesn't matter. So next below that in blue is your IABP inflation waveform. So the balloon pressure, what is the pressure in the balloon? That is what will be displayed in that. Coming to the interface, in the interface, you have various modes which are there. You have the trigger settings, the frequency, the augmentation, the various things which are there on your console. So this is how it will be looking on your. So you can get an image of this also. They may put a display of this and ask you what is the trace. Okay, so this is, and everybody can see this is a 1:1 augmentation. So I'll tell you what this 1:1 means and all. And next is you can see the pointer here. So this is the timing. So you can set your inflation deflation using these buttons here, and this is your augmentations. Here you can see there is complete LED, all the LEDs are glowing here, so that means there's 100% augmentation. And what is the ratio for your augmentation is 1:1, 1:2, 1:3. And from the picture, that is also commonly asked. I mean, no need to get frightened when they say it is a question on IABP. Sometimes they keep it very simple, not to worry much about it. They may not ask you about the timing or interpret your waveform. They may just simply ask you, so what is the augmentation in this particular picture? So what is augmentation? Anybody wants to tell? So you can write it in a chat box. So this is 1:1 augmentation. You can see every wave there is augmentation. So that is 1:1. I'll show you. I mean, and another thing to remember is whenever there is a IABP waveform, to interpret the waveform, you require at least a 1:2 augmentation. You can't interpret your IABP waveform. I mean, you can't explain what is happening with your end diastolic pressure, what is happening with your diastolic augmentation. You can't be able to comment on it unless you have a unassisted wave. So you should have an assisted wave and unassisted wave. Only then you can tell what is the effect of your IABP. So usually if they're asking you what is the effect of this, then they'll give you at least a 1:2 augmentation. You can't interpret it on a 1:1 augmentation. Okay. So these are the various buttons and display what you see on the thing. Okay, now coming to the thing. So this is how your 1:2 will look. So you have a unassisted waveform. This is a normal arterial trace. You have a upstroke, you have a peak, then you get a dichrotic notch, and then you comes to the diastole. So next is another waveform. Here you see there is some changes in the waveform. That is because your IABP balloon is inflated here, and this is a assisted waveform. See, when there is assistance happening, so your IABP is help the heart. So with that, what is happening? You are having a augmented diastolic pressure. So you see that the diastolic pressure goes high. This is an augmented diastolic pressure after your balloon inflation. And next you come to a lower pressure than the previous waveform. This is your assisted diastolic pressure. So your diastolic pressure comes down after the assistance which has happened. So your inflated balloon helps in increasing the diastolic pressure, and then your assisted diastolic end diastolic pressure comes down, which makes the heart to function better because the afterload is coming down. And apart from that, you also see that the assisted systolic pressure comes next. So that is less than your unassisted systolic pressure. So as you see further waveforms, you will be seeing it. And so what is this augmentation? This is a 1:2 augmentation. You can see this 1:2 augmentation. That is every alternate beat is being assisted. So this is your unassisted, next comes assisted, next the unassisted, next assisted. So like that it comes. Okay. So you require at least a 1:2 augmentation to interpret. In other parts, helium tank. So, what are the commonly used gas is helium. What are other gas you can use for IABP inflation? And they may ask you questions on why helium also. So helium we know is a less viscous gas. It is so because it is less viscous, it can easily inflate and deflate. So say somebody's heart rate is 100, so within less than a second it should inflate and deflate. So that fast happens only when the gas is less dense. So that is one of the reasons why helium is used. So other than that, so it is a very absorbable gas. So by chance, if there is a balloon rupture or leak of helium, so that will get absorbed. So if it doesn't get absorbed, what happens? You'll have air embolism and it will lead to complications. So to avoid that, we use helium. The other gas which can be used, which can sometimes be asked in your exams, is you can use carbon dioxide also. Okay. So these are two gases which can be used in your IABP apparatus. So this is the magnification of the waveform. So you will be seeing an arterial trace and you will be seeing a balloon inflation. This red color is your arterial trace, and you can see the gray color underneath your red color trace. This gray color is an unassisted normal arterial waveform. Okay, so here is a dichrotic notch, and when your patient is being on IABP, you would have timed it to in such a way that your balloon will inflate at the dichrotic notch. Okay, so there is increase in your this increase in your systolic peak. So this is your diastolic augmentation. This is the augmentation which has happened because of your IABP waveform, and beneath that, for your to help you out, so you can see that the balloon is also inflating there. Okay, so these two are the waveforms which we'll be seeing on the console. Okay, it will not be seeing on the patient monitor. You'll be seeing this on the console, but the arterial trace can be seen on the monitor, on the patient monitor also if you're using a arterial line. Okay, so this is how it looks. Okay, what is this entire time frame? This entire time frame is the period of your balloon inflation. So balloon inflation, upstroke, it becomes a plateau, the balloon pressure becomes plateau, and there's a downstroke when there is deflation. Again, you'll have a pause for some time, and again another inflation. Okay. So this is with respect to the balloon waveform. So this is pressure versus time. So in pressure, you see the balloon is getting inflated and the pressure in the balloon is going high. And you'll see a balloon overshoot, balloon inflation overshoot. It will go slightly high and come back. Let's say it is just like a ventilator waveform, which my subsequent speaker will be speaking to. So this is like your peak pressure on the ventilator waveform, and this is your P flat on the ventilator waveform. So it will initially shoot and then become a balance, and it will become a flat thing, and then it goes down when the balloon is deflating. So this is balloon rapid inflation and deflation. You have a overshoot and equalization plateau. So just like our ventilator waveform. Okay. So these are the various parts of the arterial waveform. So what all you are seeing? So top one is your ECG. So usually commonly used trigger is your ECG. So usually we time it. I mean, you set a trigger. We will see what a trigger is. The trigger is what is initiating a inflation and a deflation. Okay, what is initiating a inflation is a trigger. The commonly set trigger is your ECG waveform. So where does your inflation happen? It will usually happen at the peak of your T wave. You can all see at the T wave, you can see there is inflation which is happening. and at the peak of R wave, that is just before your systole. So that is when your deflation happens. So just before your peak of R wave or just before your systole, you have a deflation because the heart should pump out blood. Okay, so inflation at the onset of diastole. So you can see it as a sharp V wave. So I told you with respect to arterial trace, it will coincide with the dicrotic notch, your inflation. Whereas with respect to your ECG, it will coincide with the T wave. Okay, at the middle of your T wave. So that is when your inflation happens. Okay, so we'll read what is the physiology in the subsequent slides. This is just to show you the uh, location of the inflation with respect to your ECG trace. Okay, inflation happens at your T wave and deflation happens at your just before your R wave. So that is when after R wave you will be having a systole. So that is when your deflation happens. So occurs at the end of diastole, before systole, resulting in reduction of iron. I'll tell you the what are the parameters or the hemodynamic effects of these. Okay. And another point you should remember is these things which are there, the A, B, C, D, E, F. Sometimes they may ask you to interpret this, or they may tell you what is happening with the end diastolic pressure. So you should know what end diastolic pressure is. So what is A? A is one complete cardiac cycle. So it's from the time of deflation to the time of inflation up to the point E. From B to E is a one complete cardiac cycle. So where the augmentation has happened. So that is your one cardiac cycle. B is your unassisted systolic pressure. Sorry, unassisted end diastolic pressure. So before your waveform gets supported, that is your before your balloon gets inflated, you get the previous waveform and the base, the diastolic pressure is your unassisted end diastolic pressure, unassisted end diastolic pressure. So the subsequent one which comes at E is your assisted end diastolic pressure. Okay. So after the assistance, you see that the diastolic pressure goes down. Okay. So before that, it is high. So you see the end diastolic pressure going down. So this is assisted end diastolic pressure. This is unassisted end diastolic pressure, which is little higher. Next coming to C is your unassisted systolic pressure. So here there is no assistance from the balloon. The balloon is not yet inflated. So this is your unassisted systolic pressure at C. So D comes your diastolic augmentation. This is the amount of augmentation which has happened. So the balloon is inflated at this dicrotic notch and the augmentation has happened. And you see that is gone slightly above your unassisted systolic pressure. Correct. So this is what is the finding you see. And finally comes your E, which is your reduced end diastolic pressure. And next is your F. That is your reduced systolic pressure. This F, sorry, there is no marking here. So this is your F, which is your reduced systolic pressure, which is seen in your assisted. So, okay, in an assisted waveform, you see the systolic pressure goes down. Okay, so these are the parameters. So remember these terms. So B is your unassisted systolic pressure. Sorry, unassisted diastolic pressure, end diastolic pressure. C is your unassisted systolic pressure. D is your diastolic augmentation. E is your assisted end diastolic pressure. And F is your assisted end systolic pressure, which is less than the unassisted one. Okay. So any doubts? You can stop me at that point, or I'll be repeating these terms again and again so that you will get it registered. Okay. So no need to worry about it. So now we saw the waveform, how it happens. We saw the console. We saw the various parameters which are there on the console, how we set a console, and what parameters are there on a waveform. We saw the ECG correlation of your IABP waveform. We saw arterial trace and the IABP waveform. So now we'll see the various settings which can be made on the ventilator because this will be asked in an exam. They say they'll show you the waveform. They'll ask you to interpret the waveform and they'll ask you what should you do with the waveform. So you should know these terminologies. So you can see on the console, you have various settings which you can make. So what are the one is you can move, there is something as auto mode and a semi-auto mode. You can know by it. So auto mode is completely done by the machine itself. Semi-auto is you'll give some input and machine will do the rest. So other than that, you have something called standby, start. So these are there on the thing. Apart from that, most important thing that you should know is your trigger. So what are the triggers? I told you what is the trigger. Trigger is one which will start the IABP or it will start the inflation in the IABP balloon. So the common ones are your ECG. Because next is pressure. You have a pacemaker. Next to only arterial pacemaker. Next you have something called internal mode, which is like a default mode. So I'll tell you when to use these. What are the advantages of these? Next, so based on the source, you can set what is the say ECG, you can select which lead to select. From the pressure, you can time your pressure. So the thresholds, all of this. Next is something called as IABP frequency. So at what frequency are you supporting the heartbeat? So every beat you support, it is 1:1 frequency. Every alternate you support, it is 1:2. Every third beat you support, it is 1:3. So we would have all seen this. So just a revision, that's all. Okay. And then next comes the amount of augmentation. So you can see in this, there are 10 LED lights here. So bottom one is, it is 10% increment up to the top. So every LED light increases, you increase one, it will increase and maximum it goes up to 100%. So 10% for each LED light. So there are 10 steps here. So maximum is 100%, least is 10%. So you can increase or decrease the amount of augmentation, means amount of support which you are providing to the patient. So usually we keep the augmentation 100%, and usually when we are weaning off, we'll usually change the frequency than reducing the augmentation. So if there is any abnormality in the timing of your inflation deflation, so you have an option on the console, on the interface of the console, so you can change the timing of it. Here you can see inflation, deflation. When inflation, you can increase or decrease it. Deflation, you can increase or decrease it. So these are common settings which are there. You should know these terminologies. Okay, now coming to the triggers proper. So I told you the commonly used one is the ECG trigger. So you have a ECG waveform. From the ECG waveform, it will pick. I told you. So it is a preferred and the most reliable one. R triggers the deflation. So coming from the starting PQR, so in the R it will trigger the deflation, and T triggers inflation. So I told you inflation happens at the middle of the T wave, and deflation happens just at the R wave or just before the R wave. So if there are any arrhythmias, what to do? So there are some newer consoles which will go ahead even with arrhythmias. So even if there are significant arrhythmias, it can go out. If the patient develops a AF, yes, irregular, what to do? So no need to worry. Some newer consoles have AF trigger also. So if there's AF on your patient, if the patient was sinus tachycardia till now or sinus rhythm till now, suddenly it develops AF or some tachyarrhythmia, no need to panic about it. You can change either you can change to other triggers like pressure trigger, or you can change to a trigger called AF trigger, which is there in some of the newer machines. So it will just support the patient at every R wave. So rate is 180. So every R wave, it will start supporting the patient. Okay, no need to panic about it. Even if the rhythm is abnormal, so it will still support the patient. So next commonly used trigger is a pressure trigger. I told you if there are some tachyarrhythmias, sometimes you can change the trigger to pressure trigger and you can time it there. So whenever there is poor ECG quality, that is when we'll consider. So sometimes you have very sweaty chest, hairy chest, or your ECGs are not picking. There's some significant pericardial effusion. The amplitudes are very, very small. So that is when you'll consider using your pressure trigger. So this is one of the things. Most commonly, whenever the ECG trigger is not working, that is when you go with the pressure trigger. So where do we trigger? I told you dicrotic notch is a trigger for inflation, and point just before systolic upstroke triggers the deflation. So at the dicrotic notch, you'll have an inflation, and just before the systolic upstroke, okay, just before the arterial trace upstroke, we saw that no end diastole, unassisted end diastole. So that is when you'll see that there is a deflation. So when do we commonly use it? During CPR. So what happens during CPR? We know there is no rhythm during cardiac arrest. So you can't, your IABP can't rely on the ECG waveform. So that time what you'll do, you'll change the trigger to pressure and you'll continue. So whenever you're doing CPR, you have arterial trace. So it is producing a dicrotic notch. So the IABP will continue to function with the pressure as the trigger. If it was ECG, you can change it to pressure trigger and continue your CPR. No need to panic about it. So next comes something called as internal trigger. So your ECG is also not working, your arterial trace is not great. Then you can put it to a baseline default mode called internal trigger. So here asynchronous rate without physiologic triggering, without any trigger, it will continue to give a trigger. Like say when it happens, say when your patient has a asystole. So there is asystole. What to do? You have a IABP machine. You are still preparing to start CPR. So that time you can put into internal trigger mode. It will only set. Usually it will be set at a rate of 80. So 80 beats will be supported. 80 times the balloon will inflate and deflate. So this can also happen when your patient is on a cardiopulmonary bypass. We all know there is a non-pulsatile flow during cardiopulmonary bypass. So during that time also, during asystole or during CPP, when your ECG and arterial trace is not great, so then you will put this patient on internal trigger and your patient will be supported by IABP with a basic internal rate. Usually it will be at a rate of around 80 beats per minute. So your patient has a pacemaker. So you have a pacemaker as a spike also. Pacemaker as a trigger also. So nothing, sir. We say you have somebody who's on IABP is coming by ambulance. You don't have a doctor there. So, but you can, in that time, so you don't know the person who's there, a paramedical who's coming, accompanying with the patient, or the doctor who's accompanying doesn't have any idea about the IABP, then you can put this patient on auto mode and leave. So that will take care of the trigger part. Okay, so these are the commonly used triggers. I told you ECG trigger is the most commonest. Next commonest is pressure trigger, mainly used when ECG is not reliable or during CPR. Internal trigger when there is asystole or and the patient is on cardiopulmonary bypass. Pacemaker trigger when the patient is on a pacemaker. Auto mode when somebody with less knowledge about IABP is manipulating or handling the machine, then you can put them on auto mode. Okay. Or when your patient is in cardiac arrest, you don't know what to do, just put it on auto mode, it will take care. Okay. So we saw the various triggers. Next, I told you is level of augmentation. I told you we have those LED lights. which are there in 10 steps. 10 LED lights are there. So the least is 10%, the maximum is 100%. Usually, if you see, it will be kept in 100% because we want to give maximum augmentation. That is how much is the balloon getting inflated. So balloon should inflate not more than 90%. At least 90% should be inflated. So that why is this important? It is important because the amount of balloon inflation is what is pushing the blood. The blood is getting displaced. So that is the blood which is coming back and doing the coronary circulation. That is what is helping your heart function. That is what is reducing your IABP. So all this depends upon how much is the balloon getting inflated. So that is the level of augmentation. I told you usually we keep it at maximum 100%. So by default, IABP augments every cycle. So that is what is default when a patient is very sick. So that is what you keep at 1:1 augmentation. How do I wean off my patient? So what do we do once the patient's condition is better, hemodynamics is better, his inotropes are stable or coming down? That is when we think about weaning the patient. So then we do 1:1, we reduce it to 1:2. So that is every alternate beat is supported. Instead of every beat supporting, you support every alternate beat. The patient is doing good on that. Hemodynamics are stable, no increase in inotropes. You can change it to 1:3. And usually after 1:3, so if the patient is stable, that is when we think about removing the ABP. So timings and adjustments should be done in 1:1. That's what I told you. Say you started your patient at 1:1. So I should know what is happening with the inflation, deflation. How do I do? So start with 1:1, change to 1:2. I told you can appreciate what is happening with the hemodynamics and what is happening with the inflation and deflation only if you put it into 1:2. So change it to 1:2, adjust your timings, and then put back again to 1:1. And after that, when you're trying to wean, you can again change back to 1:2. Whenever you have any doubt about inflation, deflation, whether the timings are right or not, change the mode, change the augmentation to 1:2, see the adjustments, see the waveforms. After seeing that, again put back to 1:1. Okay, that is what you're supposed to do. Okay. So what does it mean? So, sir, you said, what is this augmentation coming down on augmentation? That means, so when the support from the machine is less, even then, if the coronary perfusion is good and the heart is doing good, that means that with minimal support also, the heart is doing good. 1:3 is the least support. In that, if he is doing good, that means that the patient can be weaned off from the IABP. So that is what it means. Okay. So a little more about the balloon. Sometimes they may ask you, how do you decide? So this may not be asked you in the CBS part. Sometimes in the CCS part, say somebody says this patient is in cardiogenic shock or heart failure, may require a circulatory support device. If you're commenting on IABP, then they may ask you, how do you decide on the IABP balloon size? The balloon size depends upon the patient's height. Okay, keep it in mind, not the weight of the patient, it's the height of the patient. If the patient's height is less than 152 centimeters, you use a 30 cc balloon. If it is 152 to 162 centimeters, it's a 40 cc balloon. If it is 162 to 183 centimeters or anything beyond 162 centimeters, it is 50 cc balloon. Okay, so use this. And why this size is important is because the anatomy, we should place the balloon between after the branching of the left subclavian and before the renal arteries. So that is what. And this length depends upon the height of the person. And that is why this size of the balloon. Okay, so that is why. So you should miss the left subclavian and you should not obstruct the renal arteries. So that is the logic behind it. That is why this balloon capacities. Okay. Now coming to how do I know the position? So that is usually done by radiography. You will be doing it in a cath lab. So you do a fluoroscopy and confirm it. Or after coming in the ICU, you can do a chest X-ray and confirm it. So in this two X-rays, in both the X-rays, it is not in ideal position. Usually the tip should be at the level of the carina, just below the carina. You can see here in the first image here, the IABP balloon has gone beyond the carina. So carina is here, it's gone beyond. So it is gone too inside, so it will be obstructing your left subclavian artery. So you monitor the left subclavian pulse. So you'll see that the pulse is very feeble or absent. So that is because your LFPP balloon is obstructing the left subclavian artery. The ideal position I told you should be at the 2 to 3 centimeter from the at the level of the carina. Okay, just in and around the carina. Whereas in the subsequent, in the second picture, the carina is here, but the balloon is too low. So here, so it is too low. So you should push it inside. So it may be obstructing your renal arteries. Okay, so in both the pictures, the balloon is not in position. When first picture, it is very too ahead. In the second picture, it is too distal. So you should push it a little more inside. Okay. So this can also be asked in your exam. So this is the X-ray, a comment on the things. Other than this, in this image, it's a radiology ED question. Okay, so there are other hardwares. I'll not be commenting on the other hardwares, but with respect to IABP, so the first one is two inside, the second one it is two outside. So you should adjust the position. This may be asked in your exam. The tip should be at the level of the carina. Okay. So now coming to the physiology. So we saw the hardware part, we saw the how to time it, how to trigger it, how to augment it, how to wean off all those technical terms we saw. Now coming to the physiological benefits. Okay, during your So again, this may be or may not be asked in your CBS. So CBS, it can be part of your what are the physiological benefits. Sometimes they can be asking you in the CCS also. So you started your patient IABP, they may ask you about the physiological benefits. So what are the benefits of IABP? We all know it improves the coronary circulation. So reduction in LV stress and reduction in LV afterload after deflation at the systole. So there is sudden giveaway. So that will facilitate the LV. The workload suddenly comes down. That will facilitate the heart to work. They facilitate the LV to work mainly. So increase in LV ejection fraction because the afterload comes down. The LV ejection fraction becomes better. So cardiac output, how much does it increase? It increases up to 0.5 to 1 liter per minute or up to 30%. So there is increase in the heart rate. Increase in the cardiac output from the baseline, it increases by 30% or it increases in overall 0.5 to 1 liter per minute. This will be asked when you're asked about mechanical circulatory support devices. Okay, each device you should know what is the increment in the cardiac output that will happen when you use that particular device. So they may ask you a question on Starling's curve also. What happens? Obviously, right side movement of the curve means the LV is becoming bad. So obviously, we are putting IABP to facilitate the LV. So you can blindly say it is leftward shift. Apart from what will happen, there is systolic unloading. And I told you, even the peripheral blood flow improves. When the balloon inflates and deflates, there is distal pushing of the blood that will improve your peripheral perfusion also. This is not very significant, but this is what they'll be asking. Another important question they'll ask you is, what is the effect on RV? So the answer is, there is no direct effect on the RV, but there is indirectly it will help. So because you're facilitating the LV, so there is some offload on the struggling RV. So some effect, some influence is there, or some help is there for RV also, but mainly it is for the LV support. Okay. So again, because it's a procedure, it's a external device, extracorporeal device. So they will be asking about the indications. You can broadly classify them to two categories of it. So one is for the cardiac failure to support your LV, like following an MI or intraoperative injury. A second one is to match your LV is okay, but there is demand supply. There's mismatch of your oxygen supply demand, and there's a significant amount of ischemic zone to reduce your ischemic zone to preserve the myocardium. So one is the myocardium is damaged and you want to support it, it is not able to function like in heart failure. The other one is to help or improve the supply demand, it is improving the coronary perfusion, so that will improve your oxygen supply. So these are two categories. The other, you can subdivide them. These are the other indications. I'll not go into detail of it. Broadly, you can classify into one supporting the mechanical function of the heart. The other one is improving the oxygen supply demand balance. Okay. Now coming to the contraindication, as I told you, any procedure, they'll ask you about the contraindications. You should know the absolute contraindications. If they're asking you the question, these four should definitely be there because they'll be getting you the maximum marks. So what are the absolute contraindications? So aortic regurgitation, dissecting aortic aneurysm, large AV shunt, and patients with chronic end-stage heart disease with you are not expecting any recovery to happen, then you may not be putting this patient on contraindications. We will not be starting him on IABP. So you should definitely know aortic regurgitation and aortic dissection. So relative contraindications like peripheral vascular disease, aortic aneurysm, severe non-cardiac systemic disease, massive trauma. These are relative contraindications, but definitely they'll ask you about the absolute contraindications. Okay. So they may ask you, so this patient has a FEMPOP in place or peripheral vascular disease. What do? You can try the other vessels. Okay. You can try the brachial, you can try the internal iliac. So like options like that are there. Okay. So again, and any procedure. So you will, whenever they ask you the complications, we always tell in our course. So it is always better you classify them, you divide them, you categorize them, and you can categorize them during any procedure for that matter. So it is intubation, ICD, defibrillation, any procedure for that matter. So you classify them into you categorize them. So during insertion, during its use, and during removal. So it will make your job easy, and you will get two answers for each. So that will cover most of your answers. Okay, you will not be missing anything. So if you blindly answer, so you may miss certain important points. So if you subdivide them, so it is easy for you to answer, and you'll get multiple answers. So coming to the complications during insertion. So what one, it can be distal peripheral vascular disease. You may not be able to canalize it. It is very, very common because it's a pretty big cannula will be inserting, a pretty big sheath will be there. The balloon should go. If the vessels are damaged, there is significant sclerosis, then you will not be able to do. That is the most common complication you will be seeing. Sometimes if you injure the aorta, it can cause aortic dissection. Malposition, I have told you, very, very important, can lead to it. Malposition can happen anytime. Okay, during insertion or during use also it can happen. So you should be very, very careful. You can tell that in both the cases. Axial femoral vein cannulation can also happen when you are not sure about the structure. So next, during the use, I told you it is a extra, it's a external device in the patient's body. Sometimes people use anticoagulation, but most of the centers they're not using anticoagulation. There is high risk of thrombosis. So peripheral embolization is possible. Once the thrombosis form, it can get dislodged. Incorrect position. I told you, if the patient moves his head, flexes his leg, or you extremely flex your patient's upper body, that can lead to dislodgement or movement of the balloon. So you should be very, very careful not to move much, not to usually keep him well sedated and restrain the leg so that he doesn't move much. Infection, if you're handling it in an aseptic way, you will get. So high risk of infection. If you're not following strict asepsis, then there is high risk of infection. Perforation of the balloon can happen, but very, very rare. So balloon rupture, balloon gas embolization, hemolysis and thrombocytopenia is a very, very common complication. Some amount of hemolysis happens because the balloon is causing trauma and it will cause damage to the RBCs and the platelets. So, and thrombosis is there. So all of this can lead to some drop in HB, some drop in platelet count. Peripheral neuropathy can happen, and timing error. I told you when you're using it, so timing error can happen anytime. So always check. How do you check? You put the patient, if he's on 1:1, change to 1:2, check the timing, and again change back to 1:1. After removal, what can happen? Yes, obviously you punctured a big vessel, removed a big catheter, so there is risk of bleeding. So complete occlusion, 20 minutes. Pseudoaneurysm can happen, fistula can happen. Sometimes your balloon can get entrapped. You kept the balloon for a longer time, some calcification has happened, so there is already a calcified vessel, so some thrombosis can happen, atherosclerosis can happen, that can trap the balloon. That is also very, very rare complication, but that can happen. So always whenever they ask you so about the complications, time them. Okay, so during insertion, during use, during removal. Say for tracheostomy also, say during tracheostomy, after tracheostomy, and post decannulation. So like that you can time them and you'll get multiple answers for that. So that will you'll be covering most of the options which the examiner has. Okay. Now coming to the part, so we have discussed the theory part. So now we'll go into what are the commonly asked questions. I told you the commonest questions which are asked about IABP are timing of your inflation and deflation. So this is again, I've told you, I've already repeated this in the previous slides. Again, I'll be reinforcing it here. So what is this augmentation? I told you if they have asked you about the IABP waveform, to interpret IABP waveform, it should be in 1:2 augmentation at least. Okay, you can't do the interpretation on a 1:1 augmentation. So I told you where should the inflation happen? The inflation should happen on the, so this is arterial trace. So where should the inflation happen? The inflation should happen at the dicrotic notch. So you'll see a sharp V there. So that means that the augmentation is absolutely fine. After that, what happens? You'll reach the diastolic augmentation, that is peak. That will be very higher than your previous unassisted systole. Okay, so this is your unassisted systole. This is also unassisted systole. So your diastolic augmentation will be more than your unassisted systole. So that what is the help of that? That is what is doing your coronary perfusion. That is what is improving your coronary perfusion. So that is the thing. After that, you see the balloon gets deflated and you see that the pressure is not falling straight down. It is going slowly and coming down. It is not a straight line down. It is slightly steep. It is going like a peak like that. Okay, so you should remember this because once it goes down straight, that means there is some error in that. I'll be discussing the subsequent slides. So after that, what happens? There is gradual decrease in the pressure and then you reach a bottom, and that is nothing but I told you your assisted end diastolic pressure. So that is what is decreasing your patient's afterload, or that is what is reducing the patient's myocardial oxygen requirement. Okay, so and you can see this point is less than the previous unassisted end diastolic pressure. So this is the assisted end diastolic pressure. This is the unassisted end diastolic pressure. You can see that the diastolic, you will also have seen in your waveform, correct? In arterial waveform, you see that the arterial pressure before IABP and after IABP, you see that the diastolic pressure is significantly low. You would be thinking, is it some sepsis or vasodilatation? That is not the answer. The answer here is because of your balloon getting deflated, you see that the end diastolic pressure comes down below the unassisted. Okay, so you see there is diastolic augmentation which goes above the unassisted systole. And you see the end diastolic pressure goes below the unassisted end diastolic pressure. These are the two common things you should always remember. And what is the purpose of this? Diastolic augmentation is one which increases the coronary perfusion, and your diastolic pressure going down is one. When the balloon deflates is one which will reduce the afterload or reduce the oxygen demand by the heart. And next is your again unassisted beat. So again you get your assisted systole. So again, so this is how it continues. Okay, I've already described this. So what should be the significant drop? I told you the diastolic augmentation at least should be 15 to 20 millimeters, and your end diastolic pressure should drop at least by 5 millimeters. So this is the most important one. Okay. So anybody now starts the questions. So we'll keep it interactive. So anybody, see, I put the normal graph also for your easy understanding. So anybody wants to answer this? You can put it in the chat box. So am I seeing the notch? I'm not seeing the notch. Okay. So what is this? So and you are seeing, so there is this unassisted systole, and immediately after unassisted systole, you're seeing there is augmentation. So what is it? Anybody? I can't see any answers. Yeah. So already there, few questions we have. So this is early inflation, right? So you can see before the dichrotic notch itself, the augmentation has happened. Okay. So see, this is what it is. So next comes, this is first thing we will be asked in your CBS question. So what is the abnormality? So it is early inflation. Okay. So what next comes, how do you say it is early inflation? What are the parameters which are happening? So mainly they're asking you about what is happening to diastolic augmentation, and they're asking you what is happening to the aortic and diastolic pressure. So that is what they'll be asking. And because of this, what is happening? So what are the hemodynamic effects? So these are the two things. First, they'll ask you to identify the timing abnormality. Next, they'll ask you what are the hemodynamic effects of it. Okay, so what is happening here? So you see that the IABP is getting inflated even before the dichrotic notch. So what is happening here? So when the uh, so this will lead to premature closure of the aortic valve. So what is happening? The heart is made to work against the closed aortic valve. So this will lead to aortic regurgitation, increase in afterload, increase in myocardial oxygen demand. So all of these happens. Okay. So what do you do? They'll ask you, what do you do for this? So what do? You'll go to the console, put it in 1:2 mode, and you, time the inflation. Okay, you make it to time when you bring it to inflate a little later. Okay, you adjust the time. I've shown you on the console how to do it. Okay. So next one. So anybody wants to take this? You can see there's a dichrotic notch. You can see after that there is some wave coming. You can see that the diastolic augmentation is not significant at all. And you can see assisted systole is less. So what is then? I think I have got some answers. It is late inflation. Absolutely right. So you can see after the dichrotic notch, after some delay, there has been some inflation. So yes, the answer is late inflation. So what do you see because of that? So yes, what do you see? You don't get the sharp V, correct? You're supposed to get a sharp V at the dichrotic notch, but here you're getting it little late and it is not that sharp also. So what happens because that I told you the diastolic augmentation down is come down. So I told you what is the importance of diastolic augmentation? I told you diastolic augmentation is one which will lead to coronary perfusion. Because the diastolic augmentation is less, you can see the unassisted systolic pressure and diastolic augmentation is less than the unassisted systolic pressure. So what will happen? The coronary perfusion will be very, very less. Okay, so how do you do? Now again adjust the timing. So ask the balloon to inflate little early. That is what you will be doing. So next, anybody wants to take this? Yes, anybody? So somebody said normal. No, normal is one in the blue, which is there. Somebody says early deflation, steep slope. Yes, see early deflation. So it was supposed to not slope like that. It was supposed to slope little slowly, but it is slow. So what is happening here? It is early deflation. So the balloon is getting deflated too early. Okay, so that means it was supposed to provide some support. Before it would complete its support, it has already got deflated. So what is happening because of that? So it will lead to you don't get significant diastolic augmentation. So it is not very effective. So the afterload reduction doesn't happen. So what is happening even before the LV starts pumping the blood, it has already got deflated. So what was it supposed to do? It was supposed to get deflated at the start of systole. Okay, but it's got deflated before that. But now the LV has to pump again the same afterload. So there is no reduction in the afterload. So what is happening before because of that? There is increased myocardial oxygen demand. So what do? Again, I time it. So I time it and bring it down to that position. If you can't time it, you are very lazy to do that. You can just put it on auto mode. It will only optimize it. Okay. Last one with the timing. So what is left behind? So this is the thing. What is happening here? So anybody? So this is late deflation. You can see very late it is getting deflated. I mean, it is easy. So obviously there are only 4 errors in timing. So I finished 3 of them. So it is easy. But in the exam, you should appreciate the waveform. Only then you'll come to know. Okay, you will not be having a normal waveform there. You will only have this waveform and you will be having 1:2 augmentation. So you should see what is happening here. Okay. So this is how the waveform looks. Prolonged rate of rise of assisted systole. So slowly it will rise. Okay. And you see that the assisted end diastolic pressure is almost the same. It is not reduced. Correct. I told you it should get reduced because the heart should get support. So because of that, what is happening? The heart is doing more work. Okay. So how do you adjust it? So you will adjust the timing. Okay. So this is how it is done. Okay. We finished the timing errors. So we have already discussed the meaning. I'll not repeat it again. Okay. So now let us go to the most important part, evidence. Okay, in the CBS itself, say they may ask you first question, comment on the IABP waveform, how do you adjust it? Next question can be, what is the evidence for it? So you will definitely be asked about evidence. So in any therapy, any mechanical circulatory support devices which you use in cardiology, everything they'll ask you about the evidence. So the common evidence which we have is, you all know about it, is IABP Shock 1 and Shock 2 trials. So what is the, I have put the bottom line. The bottom line was there was no survival benefit. Okay. And this was done in 2014. That time itself, they are downgraded. If you have seen, so there was a higher recommendation for using IABP in acute MI patients with or without cardiogenic shock. It was a class 1 or class 2 recommendation initially. But after this IABP shock 2 trial, you can see that the Kaplan-Meier curve is showing no gap between. So that means there's no mortality benefit. And there was actually much increase in incidence of some adverse events as well. So that is when they downgraded it from class 1 or class 2 in A, class 1A recommendation, they downgraded to class 3 recommendation. What does the class 3 means? Class 3 means the risk is more than the benefit. So that is what is the recommendation currently. So there's not much of a risk, or some adverse events are more when you're using IABP. That is what it is. So another study, so balloon pump assisted coronary intervention study called BCIS. So this is the study. So they saw any patient with going to PCI, any high risk patient going for primary coronary intervention, they wanted to put IABP and see what will be the effect. This study also showed that with IABP, without IABP, IABP was not much of an help. So there is no role for prophylactic use of IABP. So, I mean, you need not start IABP on a high risk primary coronary intervention, assuming it will help. But they saw that in this particular study, there was no evidence at all. So starting a patient on IABP, then doing PCI, or just going ahead with PCI does not make a difference. So that means this study said there is no need for prophylactic IABP in any patients with high risk PCI. Okay. Another large study which was recently published in your Journal of American Cardiology. So this is the study. So what was the study done? It was a very small study. So where they looked into standard care, that is routine care, and with IABP care for any patient with cardiogenic shock. So and in heart failure due to cardiogenic shock, they saw what is the effect of IABP. And in this, they said standard of care alone is adequate. So there's, you can see again in the Kaplan-Meier curve, there is no gap between the waveforms, so there is no mortality benefit. They said even standard of care alone is adequate. No need to go for any mechanical circulatory support devices. So IABP did not have any benefit. Okay. In last one, so there's something called Protect 2 trial. It's an RCT. So they were mainly looking into the adverse events. So they compared two circulatory devices. One is your IABP and the other one is your Impella. The problem here they saw is your IABP had more adverse events. Okay, and you saw the mortality was little higher. Sorry, the adverse events were higher. This Kaplan-Meier curve is about the adverse events. So they saw IABP had very high complication rates or adverse event rates compared to Impella. So they said Impella is much better than your IABP. The adverse events, not only about help in cardiogenic shock, the adverse events rates were also very high in your IABP patients. So these are other studies. I'm not going to detail of it. So you should know the name of the studies and what is the outcome. So conclusion is none of the studies showed any benefit with IABP. Okay, there is no mortality benefit. Few studies showed there was some significant amount of adverse events, but finally all studies till now there were no mortality benefit. So if you don't remember the studies, you should remember IABP shock 1 and shock 2 trial. If you don't remember the other studies, it is still fine, but those two studies should be noted and there is no mortality benefit. Okay. Now coming to, again, whenever there's some recommendation, they usually ask you about the guidelines. I told you in 2014 itself, it was downsized in the European Society of Cardiology. So these are the guidelines. What do the guidelines say? Usually they ask you about European guidelines, but this is the overall guidelines about IABP. The latest one is from ACC-AHA. It is in 2025. So in the management of acute MI, routine use of IABP in cardiogenic shock has been, again, I told you, it was a better recommendation. I think it was class 2 previously. Now they made it class 3 recommendation. That means it is not effective and may be potentially harmful. That is a recommendation for this. similar guidelines, similar recommendations from North American Society or the European Cardiology Society also. The latest guidelines from European Society of Cardiology was in 2017. I told you after the IABP Shock 2 trial, and they have downgraded it to class 3 recommendation. Okay. So let us go into a few more serious questions. So we saw the technical aspect, we saw the console, we saw the various parameters, how to adjust, how to read and all. And we saw the common CBS questions, which is about your timing of the IABP. We saw a little about evidence. We saw the guidelines. Now the common CBS questions. I want this to be very, very interactive because last few slides, I'll have some 7 questions. So with the 7 questions, I'll be finishing this. So if you make it interactive, because this is no real exam, so you can make some errors here. So if you make some errors, you'll remember in your real exam. Okay. So let us see these questions. So the first question. So I've not made the questions big. Okay, because of the time constraint. So I kept it very, very small. You don't get so small questions in your CBS in your real exams. So I kept it small only because of the time constraint, because we have 4 topics to be discussed. So I kept it very small. So I can put a big case. You'll have a case study. So this is a patient who's on so and so, so and so. So later on, the main point will be the catheter shows presence of blood. So what is the diagnosis? How do you manage? I'll see if somebody's answered. So suddenly you see that IABP balloon shows some blood. Yes, many of you have said it right. So it is rupture of the balloon. So that is what you see. So the answer is correct. So somebody said it is removed. No, there is rupture of the balloon. So what do you do? So correct diagnosis is rupture of the balloon. Because the balloon is ruptured, the blood starts entering the catheter, and you can see that the tubing of the IABP will also have blood. So how do you manage? Anybody? Remove or replace. Very good. So that is what it is. So change the catheter. So at the same time, you should be worried about embolism also, correct? Helium embolism is also a thing. First, you stop the console. You should not push further helium into it. So suggest balloon rupture or helium embolism, one of them. So immediate cessation of counterpressure. That's what I told you. First thing you do is stop the IABP machine. So it should not push further helium inside. So placement of the patient head down. Why head down? We all know air embolism. That is the common thing we do. Put the patient head down and IABP removal, and consider giving broad spectrum. Why? Though the outside of the balloon is sterile, but the inside of the balloon is not sterile, and gas chamber is not sterile. So there is a chance of infection. So your complete answer would be stop the machine. So put the patient in head down position, remove the IABP. If the patient requires support, insert a new one. And in the meanwhile, also start him on some antibiotics because this is unsterile. This was the first question. So next, coming the second question. So again, you'll have a big history about the patient. I've not put the history because of the time constraint. So you'll have and ultimately the question would be, patient IABP, the console, produces a falling alarm. You see a falling alarm. So augmentation is below the limit set. Like how you get ventilator alarms, like ventilator tidal volume is below the limit set, or minute ventilation below the limit set. Here also you can get an alarm. Augmentation below the limit set. Why do you get that alarm and what do you do? So I'll see what are the answers. Somebody says it is timing error. Check the helium level. Okay, next. Anybody else? Delayed inflation. So it is usually the alarm limits. One of the common things can be, so the alarms may be set abnormally. Either augmentation is set too high. You have expected too high, or there has been change in patient's hemodynamics. Suddenly the patient had some issue. So suddenly some acute thrombosis has happened, or new ischemia is happening. The heart function became less. So that is when you'll get this augmentation below set limit. You can understand this. Augmentation below the limit. So you say there was significant augmentation happening. Now you see that the augmentation not happening. Either the underlying heart itself, the only reason if the machine is not having problem, the only reason is the heart function is gone down. So either you can suspect a new MI happening in your patient. Okay. So there was a significant augmentation happening. Suddenly you see that the augmentation not happening like it was happening before. That means either there's a machine problem or the heart has some problem. So one of the things you should adjust, you should address both of them. So if the heart is an issue, first you check the machine. If there's no machine problem, then that means that the patient's heart is going down or functioning is bad. So you should support it. Either you add a inotropic or a vasotropic agent and improves the performance of the heart. So next, again, you have a history, and then the patient IPP, suddenly there's an alarm on the console saying no trigger alarm. What does this mean? How do you manage? So there is no trigger. Suddenly you see that the machine is producing an alarm saying, okay, sorry, I got the answer. So what is happening here? So we'll still see what the answers are. Patient is moving, change the triggers. Correct. So if it comes, the management is to change the trigger. So that means either the ECG lead should have come out. So whatever is the trigger. So asystole is correct. Yes. Best thing is if you don't know anything, change to auto mode, or you can change the triggers. Yes. I think most of you have answered this rightly. Change to auto mode is the best part. Yes, if you have auto mode, yes. Otherwise, you can change the trigger. Say ECG was there, so it is not functioning. Suddenly, your patient had AF, change to AF mode, or change a different trigger. That's what I'm trying to tell. So next question. So patient on IBP support doing good, suddenly has a cardiac arrest. So what do you do? This question I think you should answer. Has a cardiac arrest, what do you do? And next question, part of the question was, what do you do about IABP during defibrillation? So should I switch off the IABP, keep the IABP? What do I do? So somebody said, yes, correct. Put onto auto mode. You can change to a pressure trigger. Very good. Auto mode is the safest answer. So what about defibrillation? I think first question, most of you have answered it correct. Put onto auto mode, a pressure trigger is absolutely right. So what about the IABP during defibrillation? Should I stop the IABP and defibrillate, or go ahead with defibrillation, or change the current, change the position? Anything about defibrillation? Continue defibrillation. Go ahead. So yes, that's the right answer. Go ahead with defibrillation. No need to do anything with the IABP. Leave it like that, and you can go ahead with the regular defibrillation. Absolutely right. I think many of you are answering it also. So ECG trigger becomes dysfunctional. I told you there is no waveform coming, so it will become dysfunctional. So change it to pressure trigger or put it auto mode. So whatever it is. So defibrillation can be safely performed with the IABP device functioning. So no need to stop or change anything on the IABP. You can completely go ahead with your IABP, with your defibrillation as you do it routinely. Okay. Next comes the fifth question. So patient on IABP support was doing fine. Suddenly patient developed tachydysrhythmia. So some abnormal tachyrhythmia happens. The IABP starts producing an alarm and hemodynamics become unstable. So what do you do now? I've already discussed this in the theory part. So what do you do now? So already have some three answers. Put on auto mode, change the trigger. Yes. What trigger do you want to change? Auto mode, yes. Anybody else? Any other specific trigger you want to put to? Pressure trigger, auto mode, defibrillator, pressure trigger, auto mode, yes. Okay. AF trigger, yes. So you can put to AF trigger. So take it up to 110 beats. Usually the IABP will perform well, but only when it goes beyond 110, that is when it becomes very difficult for the IABP to get properly triggered. So there are some newer machines, newer IABP machines, which will work good even up to 220 beats per minute. So that is there. Or as I told you, can change it to AF trigger. And you can see, and primarily you can't do anything about the IABP. Only management is you should correct the underlying tachydysrhythmia. So start him on some antiarrhythmics or things like that. So that is what will be helping it ultimately. But for the IABP to continue to function, you change the trigger to AF trigger or put on auto mode and treat the underlying tachydysrhythmia. Okay. Last two questions. So another question, patient on IABP, suddenly there is shutdown of the console. So what do you do? Suddenly you see there's power cut or the battery goes off. What do you do? Yeah, somebody said neutral mode in cardiac arrest. That is for the previous question. So what? Suddenly the machine goes off. So this can also be asked in your. Yes, anybody? So what do you do when the machine goes off? So battery is, when you thought it is on a UPS, deflate the balloon, restart the machine. How do you restart the machine if it's some? So that's what, if battery is also gone. So machine is complete shutdown. It is not starting. What do you do? They said deflate the balloon. Anybody else? Inotropes. Correct. I mean, cardiac support you do. What do you do with the machine was the question. Increase vasopressor. So that's what you'll maintain. I mean, medically, whatever is possible, you'll be doing. Change the machine. Yes. So that will all take some time. In the meanwhile, what you're supposed to do is you will manually inflate and deflate the balloon. How do I do it? You can take a 60 cc syringe, and based on what is the size of your balloon, you can inflate and deflate. This is not to support the heart. This is only to keep the balloon inflate and deflate so that it doesn't get clotted. Because we know if we leave the balloon there, it'll be prothrombotic, it'll clot, and that clot can get embolized and you'll have complications later on. You'll do it manually using a 60 ml syringe, but that your intention is not to support the heart. It is not for cardiac support, but is only to keep the balloon moving so that it will not allow any clot to form. Okay, so this is another answer. And I think last question, again, I told you about the complications. They'll definitely be asking you the questions in any intervention you do. You will definitely get a question on the complications. So I put a small case history here. You'll not get so small case histories in your real exam. So somebody said any role of extra anticoagulation you can give, but already there is significant amount of anticoagulation, more than anticoagulation. because we all know, right? So even if you give anticoagulation, if the balloon is sitting there, a foreign body is sitting there, definitely it will lead to thrombosis. So you can give a for the anticoagulation if the risk of bleeding is less, but ultimately you should make the balloon move before you get another machine. You can do it manually. Okay. Yeah, before reading the next question already, I get some answers. So complications. So you get a question on complications. 56-year-old male patient on IABP for cardiogenic shock. Suddenly the sister comes to you saying the pulse oximeter on the left hand is not showing a reading. What is your diagnosis? I'll read the answers. Catheter displacement, do a chest X-ray, reposition it, correct. It should be at the level of the carina. Answer absolutely fine. I mean, you're all experts now. So yes, do a chest X-ray, confirm the position. Uh, And so that is not alone the answer. One malposition, everybody says. The other possibility is there can be a thrombus. Correct. That is another answer. Okay. You first answer is definitely malposition. That is what you'll be thinking. So next answer is should think about any thrombosis happening should also be taken care of. Mainly we are looking into something occluding the left subclavian. Either it can be the balloon because of malpositioning, or it can be a thrombus which is formed because the balloon is sitting there for a long time. Okay. These two are the answers you can expect. So that's the end of my talk. And as I told you, you'll definitely get, because last few exams we have been seeing, you definitely get a question on IABP. Even if could not get time to revise, you get confused, the image is not clear, don't panic. Read the entire question, because I saw one of the questions did not ask anything about the physiology of IABP or anything like that. They just asked what is the augmentation on the console. I think that is the simplest thing you can answer. So you don't need to panic seeing a question on IABP, even if you're not prepared well about it. So don't panic. Read the entire question. At the end of the question, it will be very simple, like I told you. So last time they asked, what is the augmentation on the monitor? They did not ask about physiology of the monitor. They did not ask what is happening in the waveform. They just asked, what is the level of augmentation? The answer was 1:1 augmentation. That's all it was. So simple. So no need to panic. Okay. So you have some questions. I can take some questions uh, if we still have time. Okay. So
Thank you.
main aim of
Thank you.
yeah. Thank you, sir. Thank
Yeah,
you.
yeah, Dr. Jitendra, you complete. Yeah, no problem.
Yeah. So, just summary at the end. So, main aim is not to teach you people because you already learned this. You're experts in this. You're already working as clinicians. Our main aim in 360-degree is to expect. I mean, you prepare you what kind of questions to expect. That is what we'll be tuning in our 3 months we share with each other. So, learning you can do it. You can sit at home and read, but we'll be fine tuning you how to face your exam. Okay. Can we get the PDF? I think Tapasar will address it. And thanks
Yeah.
everyone for making free and attending this session. Thank you.
Thank you, Dr. Jitendra. To crack the code, you started little bit with the system was not running, but you troubleshooted completely. And awesome lecture, and the patient could be saved, and you could manage almost 1 hour of your session brilliantly. So thank you very much. And
Thank you, sir.
hopefully this session would be very helpful for the trainees to crack the exam with confidence. And I could see the speed at which they were answering. That could show how they are now confident after attending this lecture. And thank you, Dr. Kirlos, also for accommodating Dr. Jitendra's talk and allowing him to talk before no you. And now this session is by Dr. Kirlos. He's a dear friend from Cairo, Egypt, very dynamic intensivist, and he would be again taking the next session to the excellent level about ABG, arterial blood gas interpretation. So the show is almost half now. So don't leave the webinar. We have almost 50% the literature, the talk, and the information right now waiting for you. Thank you. Dr. Kirlos, please share your screen.
Hello everyone. Is my voice clear?
Yes, it's clear.
Okay, let's share my screen. It appear now?
Yes.
Okay. First of all, excuse my English. It's not my first language, and I'm Dr. Carlos Nassim. I'm from Cairo, Egypt. I am an intensivist, and this is my lovely hospital. I am so proud to be part of it. And today I am going to give some notes about critical care examination. I have a clear advice. It's the Deathly Hallows, as I'm a big fan of Harry Potter chapters. Just three advice: be aware of time, read the vignette, and find a positive study partner. It is always about these three things. Time is not on your side. The vagueness give you 100% of the answer, and study partners are always available, but there is a few positive study partners. So keep searching for them. So today I'm going to teach about the ABG, but first of all, let me tell you something. It is not teachable; it is practicable. It's only you can practice well, and you will be good at it. So I have few notes of the ABG. We can read it with each other. Uh, we can learn about ABG by knowing the compensation formulas about the respiratory, the metabolic, and key calculation of the anion gap, corrected calcium, the osmolarity, and always search for a mixed or triple disorders in every EBG. It's not always a single disorder. So practice until differential diagnosis become automatic, and the calculation should be fast and effortless. So keep practice, keep practice. It's only way to master the EBG. So I will begin with the most important picture of EBG. This picture is from, you can have it from Google and litf.com. It has a lot of information you must memorize. It has the ABG parameters, the ABGs, the compensation, anion gap, corrected sodium for anion gap, the delta ratio, and every compensation for every metabolic and respiratory disorder. You must memorize this photo. So let's begin with a systematic approach to diagnose an acid-base disorder. I will use the physiological or bicarb-centered approach by Dr. Boston. And there is a few points to remember in the first of our lecture. First is too easy. Acidemia or alkalemia is the presence of acid or alkali. We all know that. And acidosis or alkalosis, it's a process of acidifying or alkalizing. And we all know this. Let's go to the hard point. The normal pH doesn't always mean normal arterial blood gases. And here in red, I typed pH may be normal in mixed acid-base disorder. Usually, compensation doesn't return the pH to normal, that is a high yield point. And for the purpose of calculation, we have pH of 7.4 and CO2 of 40 and bicarb of 24 are considered a normal value. So let's begin with steps how to master the ABGs. First of all, it is a bedside machine, so we can take the clinical history and other finding of the patient. And second, it is my steps to look at the oxygenation. If there is any hypoxia, it is a two critical point in exams and in CCS station of EDIC Part 2, which is the examination. I am have an experience of it. Look at the oxygenation first. Then you can assess the internal consistency of the value using the Henderson-Hasselbalch equation to know if the hydrogen ion concentration is the same as the ABG provided or not. Here are two formula. I use the first one. The first one here say subtract 2 digit after the decimal point of pH from 80. I have an example here. If you have an ABG in the exam, tell you that the pH is 70.2, then hydrogen is 80 minus 20, which is 60. Then I will come back to the ABG and have the Henderson-Hasselbalch equation, which is 24 by CO2 to the bicarb, and then it gives us about the ABG if it's normal or not. In 99%, the ABGs are normal. Then I will look at the pH and know it is a respiratory or metabolic, which is the first hard question we have. If the pH is low and the BCO2 is high, then it is a respiratory acidosis. And if it is the opposite, it is respiratory alkalosis. The thing is, in respiratory acidosis, I must, in the exam, define which type of respiratory acidosis, if it is acute or chronic or acute on top of chronic. And this table here defines the three types of this disorder. We have in acute phase, the arrow show that CO2 is high, the bicarb may be normal, and the pH is decreased. In chronic, we have increasing bicarb, and pH may be normal. In acute, on top of chronic, which is has a lot of questions in his exam, CO2 is high, bicarb is high, and pH is low. So keep a screenshot of this table. You will have it in Google if you search, but keep this in mind. And if the pH is high and CO2 is low, then it is a respiratory alkalosis from the start. But keep in mind that in primary respiratory acid disorder, that CO2 and the pH move in the opposite direction. When we have an ABG and we see PCO2 going down and pH going up, this opposite direction give us that this is a primary respiratory acid disorder. So let's go to metabolic acidosis and metabolic alkalosis. Like I said, in primary metabolic disorder, both pH and bicarb move in the same direction. And when I have a metabolic acidosis, I must calculate the anion gap. Why I should calculate the anion gap? It will help to find out the cause of metabolic acidosis, which is the cornerstone of the exam question. Find the cause to find what is the next step. Always they say, what is the cause? What will be your next step? As intensivist, your job is to answer what is the next step. So the anion gap calculation, which we have here, sodium plus potassium minus chloride minus bicarb. But in some questions, you will have the omitted potassium because of its low and narrow extracellular concentration. Potassium is often omitted from the calculation. The normal value range from 12 plus or minus 4 when the potassium is considered, and when it is omitted, you can consider the anion gap normal 8 plus or minus 4. So we will talk about the line gap. Another high yield note, which is correcting the line gap according to the serum albumin. This is the whole mark of examination. If they give you a serum albumin in the question, it is always regarding correcting the anion gap to serum albumin. And we have the two equation here. One, if the albumin is provided in gram per liter per unit or gram per deciliter unit. So we have calculated the anion gap and corrected anion gap. So let's go to the next high yield topic, which is the gap ratio or the delta ratio. So what is the delta ratio here? Delta ratio, it is the change of the anion gap to the change to bicarb. And you have the calculation here, which is delta ratio. Delta anion gap, measured anion gap minus normal anion gap, which is 12, and normal bicarb, which is 24, minus measured bicarb in the ABG. And we have four scenarios. Four scenarios, nothing, it must be memorized at the first glance. We have low, low than zero point 0.4, or from zero point 0.4 to zero point 0.8, and from 1 to 2, and above 2. And in the upcoming cases, I will show you some cases regarding the importance of delta ratio. So Uh, then we will go to the compensation of the ABG, which is another high yield of ABGs, which is asked in exams, which is the rule of compensation. Uh, CO2 and bicarb, we all know they are moving in the same direction to compensate each other, but the rate can be predicted by this formula. And I have this photo from AGKD, which you can have this wonderful paper on the internet. And you must know a golden and high yield phase, which is if the compensation is not adequate or more than expected, this is a mixed disorder for 100%. If you calculated the expected CO2 or the expected bicarb and it is not adequate or more than expected, it's a mixed disorder. So when we can go to the next slide about the urine anion gap. When I should measure the urine anion gap, if in the case I have measured the delta ratio and the ABG shows that it is normal anion gap metabolic acidosis, I repeat again, it is normal anion gap metabolic acidosis. So I should for sure measure the urine anion gap, which is sodium plus potassium minus chloride. And we have two way here. It is a positive or negative. If it is a positive urine anion gap, then it suggests low NH4, which is going to the diagnosis of renal tubular acidosis. And if it is negative, it suggests something called for diarrhea, and I have gives a table to differentiate between the two, if it's a positive or a negative. And if you are giving in the question the urinary pH, then he guide you to answer the question of the renal tubular acidosis type. If the urinary pH is more than 6, it is type 1. If it is below 5.5, it is a type 2 or type 4 renal tubular acidosis. And another note from me, you can differentiate between type 2 and 4 by potassium. The presence of hyperkalemia is suggestive of type 4 renal tubular acidosis. So let's go to the last thing. The last thing is called osmolar gap. Here we can measure the osmolar gap by measuring the osmolarity and minus it from the calculated osmolarity. Calculated osmolarity is 2 of sodium plus glucose plus urea, and then minus by the measured osmolarity on the question. I have a note, which is a very simple note. If he give you the measured osmolarity in the vignet, please measure the osmolar gap. Don't don't assume he give you something for the sake of time. No, everything is measured. They give you the measured osmolarity in the vignet to calculate the osmolarity and measure the osmolar gap. And if it is high, more than 10, it is something abnormal and which is related 100% to ethanol, and it is always about alcohol toxicity in examination. So I have here three questions which came with another type of examination before about differential diagnosis. If a case come with high anion gap metabolic acidosis with high osmolar gap, what will be your differential diagnosis? First of all, your answer must be systematic, not haphazard, not gunshot answering. You must say there is a metabolic causes like blah blah blah. There is toxins like blah 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 blah. Don't say DKA, lactic acidosis, methanol. You must be systematic. And there is a question happened here also about exogenous substance are related to increased osmolar gap. which we have here. It's always related to alcohol, and there is also non-toxical substance related with increased osmolar gap, which here have chronic renal failure, DKA, hyperlipidemia, and you will can take a screenshot, or we can send you the PDF of this lecture on the group. You will have all the answers. So that's all. Like I said, it's not teachable 100%. It's a practical. We can practice a lot, and in this way, we can find ABG more easy. And I always advise my fellow to practice bedside. Bedside, the patient is always important more than the laptop or on the mobile. So I can see comment now because I'm on the full screen. Can you see me? Can you hear me? Hello?
Yes, yes, we can hear you. Dr. Kirlos, we
Okay.
can hear you. You have finished? Okay, perfect. So thank you, Dr. Kirlos, for this excellent ABG discussion, and also it has actually covered the whole the concept and the approach how to like read the ABG in the exam at the bedside, and that would be really helpful. So any questions, or else I would be starting
I can have
the
here
last lecture.
some cases. Hello, Dr.
Yes,
Carlos.
please
I have
continue.
here some
Yes, yes,
cases we can
yes,
practice
yes.
with each.
Yeah, yeah, please.
So I can share the slide. Okay. Let's remember again the deathly hallows. Please be aware of the time, be aware to read the beginning and to find a study partner. Let's begin with the first case. I can see the. Okay. Anyone could answer this question?
That slide is not moving. Is it moving?
This is the question. Are you seeing it?
No, we are unable to see the question. The slide
Okay,
is
let's
stuck.
stop
Yeah, yeah.
and start sharing again. Windows, PowerPoint. You see it now?
No, your screen is not shared now.
Okay.
Do you want us to share the screen for you?
Okay, I share the screen, but
Okay, it's not
not
showing to
visible.
us. Okay, Bhagyasri, just 1 second.
Yes, sir.
Okay,
Yeah, can you share the screen of Dr. Kirlo's presentation on the slide from where like no he has
Yes.
stopped?
Please let me know the slide number.
okay. Slide number
You can share with me,
80.
Doctor. Yeah, I would be
Slide
sharing, no
number
problem.
50. Yeah,
50. Okay,
15. Yeah.
15. Okay.
So can I share the screen?
Yes, yes, please.
Okay, sir. So is my screen visible?
It is about to. Yeah. Go to the 15 number slide. Yes, perfect. You can make the zoom.
Yes, sir.
Okay. Uh,
Excellent.
this will be our first case.
Yes.
Have the chat. Anyone could answer this question, but please stick to the vignette, as I said, and please be aware of time. This is a 51 years old patient intubated for 3 days of pneumonia. He is on furosemide infusion, and please, if any drug are mentioned in the vignette, be aware of it. And small doses of noradrenaline. Here, the sodium is high and potassium is low. Chloride is normal. Potassium is normal. Glucose is borderline normal high. Urea is normal. Creat is high. Albumin is 18. pH is high, is not hypoxemia. CO2 is high. Bicarb is too high. And what would be your answer for this question? Next slide, please.
Bhagyasri,
Can
next
we
slide,
have
please. Bhagyasri, can you move to the next slide?
can you see my screen?
Yeah. It is now. We can see. Yeah.
Okay, that is good. Yeah, so
No, it is again disconnected.
again, why?
It is happening, something
I
happening.
think when I go to the slideshow, it disappear. You see it like this?
No problem. I am sharing right now. Don't worry. Okay, just open. These are the things that normally happen in the exam. So don't worry. We have to troubleshoot it also. No worries. Uh,
You are not seeing right now.
just 1 second. I am just sharing the screen. Yeah, your screen is now visible. You can make it in the Zoom, or else you can continue in this format. No problem. Okay, you can continue. Yeah.
When I click slide,
No,
it
no, you don't do.
disappears.
No, don't do the slide presentation. You continue like this. Okay, perfect.
Okay. So the answer here would be it is a metabolic acidosis. When I look to the BDH, it is high. The bicarb is also high. So it is going to the same way. It is a metabolic, the metabolic acid alkalosis. And when I look to the sodium, it is hypernatremia and hypokalemia, which is going for a chronic diuretic use. So in every exam, they will not ask you about what is happening. They will ask you what is the next step. It's always I am tell you the next step, and they need a focused answers like stop furosemide, deliver free water in nasogastric tube, its preferred route, and replace potassium. And every word of these answers are of important value for the examiner. So you must have awareness of the time of examination. Let's go to the next question. And I really want to see your answers. The question say, you see a patient with nausea, abdominal pain, and non-resolving acidosis admitted with DKA 2 days ago. He has been on IV insulin, and there is hypokalemia, there is hypercholesterolemia, the glucose is high, and there is albumin is mentioned. The pH is low, and the CO2 is also low. So what will be our thinking? And the bicarb also is low. So the question is, what is the explanation for these symptoms and how would you manage it? Let's go to the answers. When we have a metabolic acidosis, like I said before, I must calculate the ion gap. And here the ion gap is by calculation. Have the sodium, we have the potassium, we have the chloride, and we have the bicarbonate, which turn out to be 2. 2 here is low and normal, so it is normal ion gap metabolic acidosis. And if we have to measure the delta ion gap, it will be lower than zero point 0.4, and it directs us to the hyperchloremic metabolic acidosis of the normal ion gap metabolic acidosis. Why this happen here? It's because the chloride overload of the normal sign which I have given to the patient in the DKA, which make the acid-base disorder mentioned in this question. So my answers will be, what is the explanation? It is a normal ion gap metabolic acidosis due to chloride overload of the of the normal saline use. And how would you manage it? I will stop it and uh, replace the potassium first before the insulin. And the explanation for this case is a large volume of the normal saline during DKA make chloride load, and this bicarbonate make a bicarbonate dilution and renal bicarbonate loss, and make the patient go to metabolic acidosis. We have here two tables of causes of high ion gap metabolic acidosis and the causes of the normal ion gap metabolic acidosis. I can give here a big note. It must be read and memorize it for every exam. The causes of the high ion gap and the normal ion gap is a lot of importance for examination. Let's go to the next case. We have here a 52 years old obese man with advanced COPD presented with exacerbation, dyspneic, but not in extreme. Glasgow scale is 14. Look at this APG and describe the acid-base abnormality and why is the chloride is so low. Let's see the chat box. Okay, let's go to answers. Like I told you, the pH is low and the CO2 is high. They are in the opposite direction. So it is a respiratory acid disorder. In this case, it is a respiratory acidosis. So I think about what is if acute, chronic, or acute on top of chronic. The right answer of this question, which a lot of intensivists lose mark, they didn't define the phase of this respiratory acidosis. This and acute on top of chronic respiratory acidosis, like this table gives us guidance. And the hypochloremia, it is because the renal compensation of chronic CO2 retention of the COPD patient involve increase the bicarbonate reabsorption in exchange for chloride loss. So the chloride loss in the opposite side, there is a reabsorption of bicarbonate. So the hypochloremia reflects the renal adaptation, not a separate metabolic alkalosis. So, as a simple acid Z, chloride is low due to high bicarbonate. And this type of answers they need from you in the examination to be as fast as possible to get the mark full. Let's go to the next slide. Be aware of this question. It happened a lot in examination. It is a 27 years old man admitted with rectal bleeding due to hemorrhoids to the surgical ward. His blood count were normal. Soon after ligation of the hemorrhoids, he became febrile, tachypnic, confused. CBC shows that white blood cells, which is an arrow of red, tell you that it is 110. and the pH is low. The BO2 is 52 millimeter, and there's electrolyte, and show you that the pulse oximetry that the SpO2 is 96. So what is happening here in this case? You must have a spotty eye for the key of all questions. Here you have hypoxemia in the arterial system, but the pulse oximetry show normal saturation. This has a coloration. Let's go to the answers. This is something called, and it is a high yield for examination called pseudo hypoxemia, which is leukocyte latency. Let's break it down. So note that there is hypoxemia in the blood, but the pulse oximetry is normal. This discrepancy occur in leukemia. This is called pseudo hypoxemia. The simplest example is that increased in blood cells, which is white blood cells, consume a lot of oxygen cells. The blood is low, Ba2 is low, but the plasma BO2 is normal in such case. Please also note the potassium here is 6, which may be due to acidosis, due to extracellular shift of potassium, or pseudo hyperkalemia, which is occur in raised blood count, which we have here the white blood cells. So let's go to the next question. A 30 years old man presents with fever, vomiting, sweating, confusion, and agitation. The following values are measured on the arterial blood, describe the acid-base status, and name two possible diagnoses. And I repeat, here the pH is normal. Let's go to the answer. This is a triple acid disorder. How I know it is triple acids? Let's go to the last of the answers. It is a salicylate toxicity. Here, there is pH of 7.4, PCO2 of 25, and the bicarbonate is 50. I assume that it is a metabolic acidosis, so I calculate the anion gap, which here is 20, and the 20 here is high. So it is a patient with a high anion gap metabolic acidosis. In high anion gap metabolic acidosis, I must calculate the delta ratio. Delta ratio here, it is more than 2. So it is there is another acid base disorder compromising the high anion gap metabolic acidosis, which is high anion gap metabolic acidosis with pre-existent respiratory alkalosis. Why this happen in salicylate toxicity? It's because salicylate directly stimulates the respiratory center in the brainstem, causing primary respiratory alkalosis and also cause a high anion gap metabolic acidosis by uncoupling oxidative phosphorylation, leading to lactic acidosis. So it is a mixed type of acid-base disorder. And here we have the explanation of the book. I think it's the same. And I am always telling my friend in examination, they are focusing more on mixed disorder. It is not about only the single primary disorder. Let's go to the next slide. And I think it is too easy. You see it, or I can zoom. 40 years old man is pulled from a house fire and brought to the emergency department in the early hours of the morning, and the paramedic estimate he is likely to have been trapped in smoke-filled room for about 20 minutes. The examination of the patient is heavily contaminated with tooth and smells strongly of smoke. Fortunately, he has sustained any thermal injury. He appeared to be confused and has just vomited. Baseline observation are normal with an oxygen and saturation of 99% of 15-liter oxygen mask. And here we have the labs. Be aware of something really high yield. When you see the labs here, and you spotted cardiac monoxide assay, which here calling for 40, and the slide here gives you that non-smoker it is okay for below than 30, and in a smoker it is okay below than 10. So I think we all have the answer, which is carbon monoxide poisoning. So uh, why this patient is hypoxemic? Because carbon monoxide bind to hemoglobin 200 times the affinity of the normal oxygen, and therefore it is carried on the hemoglobin molecules in preference to oxygen. So, as a consequence, the percentage of hemoglobin saturation with oxygen is markedly reduced in carbon monoxide poisoning. So, there is not a question here going to what is the next step. If you don't tell the examiner what is the next step, it's not you give him we can admit it as ICU and blah blah blah, and never said apply oxygen to the patient. It's a fatal mistake. Oxygen is of a priority here in this case. Don't forget about the oxygen. Let's go to the next slide. I think this is the last slide. 36-years-old man admitted to the ER in the middle of the night, complaining of vomiting, malaise, visual problems, and shortness of breath. The patient respiratory rate is 32 and chest is clear on auscultation. The investigation show he gave me electrolyte and he gave me an ABG, and he told me that the measured serum osmolarity was 45. And I told you before, if he give you a measured serum osmolarity, you must calculate what we will know in the answer. While the patient was being treated, 16 more patients with a similar history were admitted to the ER. All gave the same history of drinking cheap country liquor for a local outlet. What will be your diagnosis? I think we all have the diagnosis, which is always related to alcohol. But how we can answer this question? I give this question to know the approach, how to answer this question. We have pH here is low, and the CO2 is low, so it is a metabolic disorder. The bicarb here is low, so it is a metabolic acidosis. So I can measure the anion gap. Here, the anion gap is 23, which is high anion gap metabolic acidosis. And when I calculate the delta ratio, it gives me 1.3, which suggests of uncomplicated high anion gap metabolic acidosis. So when he give me serum osmolarity, I must calculate the osmolar gap. When I calculated the osmolar gap, it is too high. It is 140, and here the osmolar gap is increased more than 10. There is no other obvious cause of increased other gas other than methanol or ethanol toxicity. So this patient, when came to the ER, I must first of all ABCD, but not mentioning it, the antidote of alcohol toxicity, and must send for toxicology screen because it diagnosed with toxicology screen, and don't miss if it is refractory to the medical treatment, you can initiate hemodialysis for the alcohol. Let's go to the, that is the last slide. Think here, yeah, this is the last slide. A 55 years old male is admitted to the ER with suspicion of intoxication. He is confused on polypia on clinical examination. He has a central as well as peripheral cyanosis. His pulse oximeter reads 85 on oxygen 7 liter. The examination is otherwise normal. The patient has a history of eosinophilic cellulitis and alcohol abuse, and a prescription of Tapson is noted. Be aware of any drug mentioned in the vignette. He gave me an CBC and electrolyte and an ABG. So describe the most significant finding and what will be likely diagnosis. Okay, in the chat box, they answered right. Yes, it is methemoglobinemia. The hypoxemia on the pulse oximetry and the hyperoxia on the ABG. It is the most suggestive way of methemoglobinemia. Most important findings here we have lactic acidosis with respiratory compensation. The elevated CK also must be mentioned. I give this question to we all forget about the other pathologies in the cases. I must say there is high CK indicated rhabdomyolysis, and believe me, that is answer of their answer sheets of EDIC Part 2. I must say all the pathology. So when I recap the APG lecture, this is the last question. You must practice a lot. So thank you very much for your time, and I hope I give a helpful lecture. And again, excuse me for my English; it's not my first language. And you can contact me anytime on WhatsApp. Feel free anytime, and you can join my WhatsApp channel for any question you have, particularly for EDIC Part 2. And if I have an advice for this lecture, I only give this to all my candidates for exam. Be aware of time, read the vignette, it has 100% of the answer, and find a positive study partner. Thank you all, and I wish to have another lecture another time.
Thank you, Dr. Kirlos. If you can stop sharing, then I can start sharing my screen. And in the meantime, there is a question in the chat box about what is the importance of base excess. So I would be taking the question if you don't mind, Dr. Kirlos.
Okay.
Okay, so base excess is actually the metabolic component of any acid-base balance, independent of PaCO2. So here PaCO2 is not important when we are discussing about base excess. Now base excess less than -2. This is metabolic acidosis. That is base deficit. It is not base excess now. Now if base excess is more than +2, it is metabolic alkalosis. That means excess base is there. Now this reflects the severity of the metabolic disturbance better than pH alone. So when we have base excess along with the pH, so that would be guiding us whether we are dealing with the severe form of metabolic acidosis or alkalosis. Now this is useful in shock, sepsis, decay when we are dealing with diabetic ketoacidosis, and trauma to assess the global metabolic stress. So remember these words. If the examiner asks you, you can use these words. That would be very impressive. Global metabolic stress. And this helps to track the response to the therapy, whether we are giving fluid, whether we are like doing the RRT for the metabolic acidosis or the bicarbonate therapy. So always remember base excess changes are actually directly proportional to the metabolic problem, and PaCO2 changes would be towards the respiratory problem. I think I have tried to clear little bit of air around this base excess. So remember -2 +2, base excess, base deficit, global metabolic stress. Perfect. So if you all allow, so I would be taking you to the last lecture. Before that, Dr. Kirlos, once again, thank you from 360 Critical Care team for sharing your expertise to all of us. And hopefully this lecture would be beneficial to all the critical care trainees and the examinees. Now, last but not the least, the fourth lecture, and this is something once we enter into the ICU, the beep, the alarm on the ventilator, you would be trying to solve the problem with the ventilator graphics. So the topic title is when curves peak, we need to understand the ventilator graphics. This is one of the quote that I just found from the literature, that ventilator graphics are nothing, rather they are the signals coming out of the patient, going into the ventilator and pop up on the screen. This is by Warren Sanborn, and this is so appropriate in our day-to-day clinical practice. Now, why graphics? Why graphics are important? Graphics are waveforms that reflect the patient ventilator system and their interaction. Simple. So if the examiner asks you why we need ventilator graphics to the analyze and interpret and troubleshoot our patient's hemodynamics and also ventilatory requirement, so we need to be very thorough that the purpose of monitoring the graphics are to allow the users to interpret, number one, evaluate and troubleshoot the ventilator and the patient's response to the ventilator. It's not only the ventilator, how the patient is behaving to the ventilator, monitor the patient's disease status. The most important in the respiratory ICU or the patients on ventilator for the region of pneumonia or respiratory problem is the compliance and the resistance of the airway. Assess the patient's response to the therapy that we are using, whether it is bronchodilator, whether we are giving steroids, whether we are dehydrating by doing deresuscitation. So we all need to know with the graphics how it is actually affecting. Monitor the proper ventilator function, and finally allow the fine tuning of the ventilator to decrease the work of breathing, which is the utmost importance in our the clinical the area. Optimize the ventilation and maximize the patient comfort. That is our goal when we are deciding to put the patient on ventilator. Now, just a simple physics that I will be taking you into the next 4 slides. How a breath is delivered. Simple. There would be the baseline PEEP, there would be inspiratory phase, then there would be expiratory phase. And you have seen here, time is in the x-axis, pressure is in the y-axis. Now, here comes the patient's trigger. Patient is trying to breathe, and that is initiating the inspiratory phase. So the blue mark is the trigger. So patient is trying to take the breath inside, and that is actually triggering the ventilator to give the breath. Now, the trigger has already been given. Now the patient is trying to take the breath, but till what time, till what volume, till what pressure, that would be depending on the target that we are fixing here. So the inspiratory phase will end when our target is fulfilled, whether it is volume or it is pressure. Now, once the target is achieved, then there would be a cycling phase. And the cycling phase would take our patient or the ventilator to the expiratory phase, and it would be again coming to the PEEP set PEEP level, and it will be continuing, and then there will be a new trigger, and the patient will be again taking to the inspiratory phase with the target and the cycling phase. Clear? So this is a basic idea how a breath is delivered. Now, what are the types of waveforms? That would be something very important before going into the detailed analysis of the waveform. So the waveforms can be divided into scalars and loops. Scalars, they are actually plotting the pressure, the volume, and the flow against the time. And here time is the x-axis. That means pressure, volume, and flow will be in the y-axis. And this is one form of scalar. Clear? Now, loops are plot that pressure or flow against volume. So that means PB, FB. There is no time component in the loop. And this would be looking like this is flow time, flow volume. Clear? Now, so these are all the, like you would say, the pressure time, volume time, and the flow time. Clear? Now, can anybody tell me what is the mode here in this scalars that I have said here? Anyone? Yes, 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 perfect. So you all know, yes. So all these are basic things. The examiner may show you some of the prefixed the images, and they will be trying to get the answer from you, because in the exam it is not the time to go into the detail how these are actually formed or what are the basics, but I will try to give you a lot of pictures, images, so that your idea would be more robust before the exam. And these are the flow volume and the pressure volume, which are the loops. And you can see here in the flow volume, inspiration would be above the baseline and expiration would be below the baseline. So it would be, you can see inspiration and then expiration. And in the pressure volume, you see the exhalation goes up. There would be peak inspiratory pressure, and then the inhalation happens, and it would be again going in this direction. Clear? So this is the concept with which we should be going into the basic shapes of the waveform, and these are the basic shape of the waveform. The examiner may ask you, like, is there any other waveform you know shape apart from the square or the sine? So it is ascending ramp, descending ramp, sine wave, exponential rising, exponential decay. Clear? Now, what are the types of waveforms? If you will say like the square wave, it represents a constant or set parameter. If we have taken the pressure maximum to be 20, so it would be delivering till the pressure reaches 20. Now, the case with the ramp wave, it is a variable parameter. Like it will vary with the changes in the lung characteristics. It can be accelerating, it can be decelerating. And sine wave, it is seen with the spontaneous unsupported breaths like this. Clear? Now, if we are trying to differentiate between the volume mode and the pressure mode, I asked you the question 2 slides before. The volume mode, you will get the pressure wave scalar like this, flow scalar like this, and the volume scalar like this. This is volume control. In the examination, they will try to confuse you. So you have to be very sure. In the pressure mode, the characteristic feature would be the pressure scalar would be in the square form because it is set. And in the volume mode, the flow, the target would be square. Okay, these are the two things if you are getting. So you would be very sure that you are dealing with either a pressure mode or the volume mode. Concept clear? Now, we need to now fix the problem. But in case we don't able to fix the problem, so we will be just shooting the system. Please don't shoot the examiner. They are like no poor people, so they are just trying to assess you so that you become good intensivist. So at least you try to solve the problem so that they would be happy. So this is something with which we'll now proceed ahead with the pressure time waveform. Now the uses when we are dealing with pressure time, I have already shown you the scalars, air trapping, whether it is auto PP generating, airway obstruction, bronchodilator response, respiratory mechanics, compliance or resistance of the airway, active acceleration, breath type, whether it is pressure or the volume, peak inspiratory pressure, P plat, CPAP, PEEP, and asynchrony. So these are the uses with which we can like get the pressure time waveform in a proper way. And finally, the triggering effort, whether patient is able to trigger the ventilator. I have shown you initiate the inspiratory phase. Now pressure time waveform, what is happening here? Here you can see the patient effort by the negative deflection here. Here no patient effort, here patient effort. And you can see here the PEEP, the 5 here is the PEEP that is set. So PEEP is plus 5, patient effort is happening here, but in some of the ventilator breaths, they are not patient initiated or triggered. Now, this is the basic standard pressure time waveform. You should be very thorough. Now, if you start here, the begin the inspiration. Here 1 is the peak inspiratory pressure, PEEP. Now, this part is the inspiratory, and you reach here at the end inspiratory pressure, the pressure which is named as plateau pressure, P plat. Now here the A and B, here if you draw the line, the expiration happens here, and this is the expiration phase. Clear? Now what is happening? The B here is the alveolar distending pressure. And that is the whole idea why we want the ARDS, the low tidal volume ventilation with not distending the alveoli more than what is expected or that is required. So airway resistance would be the A part and B part is the alveolar distending pressure. Clear? So if it is rising, so you will be like labeling that whether the resistance part is actually affecting. But if it is affecting in the B part, you will say there is a compliance problem. Alveolar over distended. So you need to be reducing the PEEP so that we are not over distending the alveoli. Clear? Now, increased airway resistance due to n number of causes that we know. Increased the kinking of the endotracheal tube, secretions, bite, maybe like anything that is affecting bronchospasm. So all these things would be increasing the peak inspiratory pressure. And this is the airway resistance. And the plateau pressure would be at the normal level. But if you are getting the compliance to be decreased in case of severe ARDS, your plateau pressure rises and anyway your peak inspiratory pressure would be the high, or it would be compensated with rise in the plateau pressure. That means the airway resistance will not be the problem here, rather it would be the plateau pressure. Clear? In the ARDS, you will get the plateau pressure to be high. Now, air trapping. Sometimes what happens if we are suspecting that auto PEEP is getting generated, we do the expiratory hold maneuver. In the examination, believe me, the DRNB examination on February 3rd and 4th, you are getting this and you remember me. How to do expiratory hold and what will be the utility of expiratory hold, how you would be deciding whether this patient is generating auto PEEP, what will be the total PEEP, and what would be the optimum PEEP, what is physiologic PEEP. So the examiner would be bombarding you with almost 7-8 questions on PEEP. So please clarify all the things with 1 or 2 lines because you will not get enough time to take 5 minutes of time for the PEEP only. So you have to be very crisp and answer to the point. Now here, when I'm doing the expiratory hold maneuver, I am getting the PEEP here, which is this is expiration is now almost in the plateau phase, and you are getting +9 here. So that is the auto PEEP. If you are not getting it, that means there is no auto PEEP. So your set PEEP is +5 and your auto PEEP is +9. So total PEEP is 9 + 5, 14. Clear? Now coming to the pressure time waveform, if you are getting this type of waveforms in the pressure time, so what is happening here? You're actually the flow starvation happening. So flow is not adequate. So you have to increase the flow to reach to the expectation of the patient. Okay, otherwise there would be this flow starvation would be happening. This is like something scooping. Okay. Now Coming to the volume time waveform, what are the utility of the volume time waveform? This can be used to assess the air trapping. Again, we can get the air trapping auto peep, leaks, that is most important here, knowing the tidal volume, active acceleration and asynchrony. This is your something. Now you can see inspirated tidal volume is the maximum here. You are inspiring here, reaching here. This is the maximum inspirated tidal volume. Now here you are beginning the expiration and accelerated volume now returning to the baseline. So this is the volume time waveform. Now, if the acceleration side of the waveform doesn't return to the baseline, it could be from air trapping or could be due to leak, like endotracheal tube leak, cuff leak, ventilator circuit leak, or if there is a chest drain, maybe the chest drain, there is some amount of leak happening in the chest drain. Now, that's why the waveform would look like it is going in the inspiratory phase, reaching the peak inspiratory volume, but in the expiration, what is happening? There is a loss of volume here happening. And then again, your ventilator is giving the inspiration and it is reaching the peak inspiratory volume. So there is a definite loss of volume is happening here. And that is guiding you that you have to troubleshoot something so that there would be no loss of volume. Now coming to the flow time waveform. So flow time waveform would be looking like this in the pressure mode and in the volume mode. In the volume mode, it would be the square wave, and the pressure wave, you will get this descending ramp pattern. Now, if you are getting the volume mode, this is the inspiration and your expiration is happening from here. Clear? And in the pressure, it is a descending ramp. So you can see your inspiration and then expiration. Okay. So it is a constant flow happening in the volume, but in the pressure, it is a decelerating flow. Now, flow time waveform can be used to assess the air trapping, that is auto peep. So auto peep you can see in all the three: pressure time, volume time, and flow time. Airway obstruction, bronchodilator response, which is very good for diagnosing and treating the bronchodilator in the flow time. Active acceleration, breath type, whether it is a pressure or volume, that I have already told you how you will be differentiating whether it is pressure generated or volume generated. Inspiratory flow, asynchrony, and triggering effort. Okay. Now there are certain troubleshooting that I would show you in the flow time. So now here what is happening? The inspiration, then expiration. Now expiration, the expiratory flow is not returning to the baseline here. That means it should go in this direction. But now it is going in the, somehow it is going below. So that's why what will happen? So you will be getting a little bit of the idea that it is actually not reaching to the baseline. It is taking a longer time here. So that means you are somehow stuck here, and the start of the next breath is happening from here. Okay. Now, if your patient is a COPD patient and you are getting the expiratory waveform, which is taking a long time, that means the adequate expiration is not happening, the acceleration is not happening, and there is dynamic hyperinflation happening. So the examiner would be expecting that you should say that the peak flow is not optimal, right? Pre-bronchodilator you here, the peak flow is somehow here stuck and it is taking a long expiratory time. Now, if your COPD patient, you have started on nebulization, what is happening? Post bronchodilator, your peak flow, it is now getting shorter expiratory time because you are actually allowing the bronchospasm to be relieved with the bronchodilators. Clear? Now, coming to the loops, and the first loop is the pressure volume loop. Now, I have shown you the diagram of the pressure volume. The examiner may expect you to draw it in your exam. So just remember volume and pressure. So volume would be in the y-axis and pressure would be in the x-axis, and it would be like this. Okay. Now, so volume is on the y-axis, pressure is on the x-axis. Inspiratory curve is upward, expiratory curve is downward. So I have already told you. Clear? Inspiratory, expiratory. Okay. Now, spontaneous breaths go clockwise and positive pressure breaths go counterclockwise. So that is again one of the important things. So clockwise it would be spontaneous. You will be seeing it is a spontaneous breath. But positive press it will go anti-clockwise. Okay. Now the bottom of the loop will be at the set peep. So peep would be the first initiating point, and it will be 0 if you will be not putting any peep set. Now, if an imaginary line is drawn down the middle of the loop, the area to the right represents the inspiratory resistance and area to the left represents the expiratory resistance. Now, by the pressure volume loop, what are the utility? They used to assess the lung overdistension, airway obstruction, bronchodilator response, respiratory mechanics, work of breathing, flow starvation, leaks, and triggering effort. Clear? Now, I have already like explained the theory part. Now looking at the picture. So this starts from like here, bottom is 5. Now here you can see here inspiration happening and this patient is getting positive pressure. So it would be counterclockwise or anti-clockwise. Now if it would have been in the spontaneous part, then it would have been going in this direction, clockwise. Now here is the dynamic compliance. This is the joining point of the two inspiration and the expiration at the maximum level. And here the expiration happens. So it is just like you can see this is the counterclockwise. And you are putting a line here in the middle of this loop. And the right side would be inspiration. The left side would be the expiration. Clear? Now, just think about if there is a beaking happening, just like a bird's beak. That means you are actually over inflating to the your tidal volume what you have set. So that means you are actually trying to do some harm to the patient rather than any benefit. So you have to take care of low tidal volume so that there would not be volume trauma or villi trauma. Now coming to this pressure volume loop where you are getting some resistance, the troubleshooting, the problems. Now if you are getting increased expiratory resistance, it would be slightly swollen. You can see here, it is all stressed to the expiratory part. Normally it should be in the black. You can see here. Sorry. So you can see here, like you would be looking at this would be, and this would be the normal thing. Now what is happening? If there is increased expiratory resistance because of the secretions, bronchospasm, it is getting stretch here, right? And now if you are getting increased inspiratory resistance, like king tube, patient biting, that means your inspiration is not affecting, like you are not like no being delivered in a proper way. So it is again getting stressed. Clear? So these are the basic things that you should be like doing it. Otherwise, if in the examination they would be like expecting that you should be talking in a very lucid manner and again confidently. So that would be something you need to be very clear. Okay. Now, what is hysteresis? I have written in the middle of this loop hysteresis. The examiner are very fond of asking this question. So, hysteresis is the difference between inspiratory and expiratory limb of the pressure volume loop that I have shown you. Now, it reflects the energy loss during a breath due to alveolar recruitment or de-recruitment and tissue resistance. So, it's all related to the recruitment, de-recruitment and tissue resistance. During inspiration, higher pressure is needed to open the collapsed alveoli. During expiration, alveoli remain open at the lower pressure so that you don't need to again and again reopen it. So that's the idea of like avoiding the atelic trauma. Okay, so we need some amount of PEEP so that again and again we don't need to open it, and that would be more like damaging and releasing the cytokines. So the area within this loop represents the magnitude of the hysteresis. Now the clinical relevance, because we need to always correlate with clinical thing. So large hysteresis suggests unstable alveoli. Like if you are getting in the last picture, it is actually large hysteresis. The inspiratory part is actually distended. So that is unstable alveoli, ARDS, and that supports using adequate PEEP to minimize the cyclic collapse. Now, in this pressure volume loop, if you are getting towards the left side, that means increased compliance. And increased compliance example are emphysema. In the pediatric population, surfactant therapy. Now, in the decreased compliance, the inspiratory phase would be descending, or it would be towards the right side. That the most important thing for us is the ARDS CHF atelectasis. Now, if you are doing some maneuver and you are treating the patient in the low tidal volume ventilation with adequate PEEP, so maybe next day, 24 hour, 48 hour, you can see this one which is tinting towards like the right side, it would be going again towards the middle part in the center. So that means your treatment protocol is working. Now, coming to the flow volume loop, flow is plotted on the y-axis here and volume on the x-axis. Now, these are the loops which are used for same as like what we are using in the pulmonary function testing, PFT. So, ventilator graphics is equal to the pulmonary function test. Now, inspiration is above the horizontal line. I have already told. Expiration is below, and the shape of the inspiratory portion of the curve will match the flow waveform. I will be showing you all in the picture. Now, the shape of the expiratory flow curve represents passive exhalation because there is no active thing happening. So, expiration is always passive. Now, that can be used to determine the peak inspiratory force, peak expiratory force, and tidal volume. And that would be somehow in the spontaneous breath, you will get the flow volume loop to be circular. Now, that can be used to assess again the similar things that I have already discussed: air trapping, airway obstruction, airway resistance, bronchodilator response, inspiratory expiratory flow, flow starvation, leak, water or secretion accumulation, and asynchrony. Clear? Now, coming to the picture. Here inspiration, now the expiration. Now expiratory part of the loop is not returning to the starting point. That means there is a definite significant leak is here happening. Okay. And you can also quantitate the leak, the volume leak, how much is actually affecting. So if you are going to almost like it should be 450, but here you are almost losing at 250. So that means it is not reaching to the baseline. Now, if you are getting obstruction also in the flow volume loop, you will be getting reduced peak flow and there would be scooping here. So that means definitely the obstruction is happening, and this is the normal PFT view. So the examiner asks you what would be the normal thing. So normal thing is like this. Now, I would be now at the end would be giving you a structure approach to analyze the ventilator graphics. Just remember the steps in the examination. If somebody will be asking you, can you summarize or like analyze in a very structured approach the ventilator graphics? So you can start with like this. Step one, identify the mode and the control variable. Say this first. Examiners would always look for whether it is volume control, whether it is pressure control, pressure support, SIMB mode. Control variables, I have already told how you will be distinguished between volume control or pressure control. In volume control, flow is set, pressure varies. Pressure control, pressure is set, flow varies. And in the Viva, always before analyzing the graphics, you will be saying that I will be identifying the ventilator mode and the control variable. So ventilator mode is, I have already told you, and the control variable is already between volume control or pressure control. Now the second step, the examiner would be showing you the graphic, or in the practical on-site exam or in the online exam like EDIC 1, EDIC 2 or any fellowship exams. So you will be expected to identify the graphic, clearly name whether it is a scalar or a loop, and again in the scalar whether it is pressure time, flow time, volume time, pressure volume loop, flow volume loop. Never jump into the interpretation without naming the graph. The examiner may sometimes feel that you are mocked up by looking at the picture, but you are unable to actually have a structure in your mind. So that is very important. If you start in a structured way, so maybe if it would be difficult also, you would be reaching to the correct conclusion. Are you getting it? Now, step 3 would be analyze the baseline. Look at the starting point of the curve. Is the baseline pressure is equal to PEEP? I have already said you. If it is starting at little bit above, that means it is starting at the PEEP level. So PEEP you have set at 5. Now, does the expiratory flow return to the 0? If no, that means auto PEEP is there. In the flow time, I have shown you, if it is expiratory flow is not reaching with each breath, it is actually going little bit below the baseline. That means there is auto PEEP. So it is not reaching to the baseline. Now is baseline volume 0? If it is volume, so you will be again saying whether it is 0 or not. So in the exam, if failure of the expiratory flow to reach 0, that would be indicating there is some amount of air trapping. Clear? Now step 4 would be inspiration. Analyze the inspiration. So you have first identified the mode and the control. Second, the graphic, whether it is a scalar or a loop. Then start from the baseline. Then baseline, from there you will be going inspiration. Now inspiration, you ask 3 questions. The shape, whether it is square, decelerating, scooped, smooth or irregular. I have shown you few of the images that would be guiding you. You will be getting some of the troubleshoots there. Magnitude, in the inspiration you will get the peak inspiratory pressure, the delivered tidal volume, the peak inspiratory flow, depending on whether you are dealing with the flow time or the pressure time or the volume time scalar. Now coming to the third one is the time. In the time you will be getting the inspiratory time, I ratio. Clear? Shape, magnitude, time. So in the Viva, inspiratory limb gives you most important information about the resistance, compliance, and the flow adequacy. Clear? So now till 4th step, you are all clear? Now 5 step, after inspiration, you will be analyzing the expiration. Now in the expiration, you will be asking these 2 questions. Does the expiratory flow return to the 0? That means normal. If it is remaining positive, auto PEEP. Maximum, almost 75% questions in any of the exam, the examiner would be revolving around auto PEEP. So always don't hesitate to use this if your expiratory flow is not returning to the 0. Now if there is any expiratory flow limitation, so you will be saying whether you are dealing with premature cycling, sudden cutoff. So here comes the 2 concept, whether it is like the premature cycling or delayed cycling. I have shown you the picture in the 3rd or 4th slide where you are getting the trigger, then the target, and then the cycling. So cycling may be also be the one of the troubleshooting for you. So expiration tells us more than inspiration in the obstructive disease. Inspiration would be more informative for the compliance problem, like ARDS problem. Clear? Now coming to the step 6, you have to differentiate between resistance versus compliance, because already from the inspiration and the expiratory analysis, you have now got an idea whether the problem is related to the resistance or the compliance. Now in the examination, again, believe me, plateau pressure they would be expecting from you in very clear and concise manner that would be reflecting the compliance. Peak pressure reflects resistance plus compliance. Peak pressure is never only resistance. If your plateau pressure will be rising, as a result, what would happen? Anyway, your peak pressure would be high, though the resistance component will be same. Are you getting it? So peak pressure is actually combination of the plateau pressure, that is the plateau pressure plus the resistance pressure. So it is never the only resistance. So that is something myth that you will be dispelling at this point of time. Now step 7 would be look for the ventilator patient asynchrony. Till now you are concentrating on the ventilator screen, but at this point of time when you have already analyzed starting from what is the mode, what is the scalar, then what is the baseline, then the inspiration, then the expiration, then the resistance and compliance, you would be looking at the patient. The examiner would not be very happy if we will be only focusing on the ventilator. Like the monitors, we are not treating the monitors, we are treating the patient. So that's why always actively search for whether it is ineffective triggering, double triggering, flow starvation, delayed cycling, or auto triggering. So any mismatch between the patient effort and the ventilator delivery, that would be indicating asynchrony. So these words you have to use if in your examination. Now step 8, everything you have to integrate with the clinical context. By looking at the patient doesn't solve your problem. So always trying to create one story, whether this is a case of ARDS, then landed up in the pulmonary edema. Now your compliance is poor, patient is not getting the proper oxygenation. Whether the patient is acute exacerbation of COPD, now you are getting the auto PEEP generation, dynamic hyperinflation, hypotension, you need to optimize the PEEP. Whether you need to give sedation to the patient so that the patient will not get the double triggering. Whether you need to give some fluid because the PEEP requirement is very high, that is actually affecting your venous return. Whether you need to do the FBG to look at the oxygenation and the ventilation part, whether you need to be ordering this FBG 4th hourly, 8th hourly after doing the maneuver. Whether you need to do some maneuver on the ventilator like inspiratory hold maneuver, expiratory hold maneuver, recruitment. So all these things would be the pet question of the examiner. Like, so always the last line would be ventilator graphics must be interpreted in the clinical context, not in the isolation. Now, last one, just integrating doesn't solve your problem. The examiner would be expecting that as a doctor, as a responsible intensivist, as a consultant, you need to suggest the corrective action at that time and do it also. So always the examiner would be expecting you not to only verbalize. Some smart candidates, they can just answer everything, but when they are being asked to do it on the ventilator, they fumble, because you have to be confident to do the corrective action on the screen, on the monitor, and see again, look at the ventilator, do something, then look at the patient. Your movement of the head would propel the examiner that yes, this candidate has worked at the bedside and he has done it, not only advising, and the respiratory therapist or the doctor, senior doctor has done. So examiners love this step. That's why I have kept this word. Examiner love this step by you will be increasing or decreasing the flow, adjusting the PEEP, change the inspiratory time, modifying the trigger sensitivity, maybe from the 40% you are changing to the threshold of 20%, considering changing the mode. If you are not happy with the ventilator with the volume control, you change it to PRVC, you are changing to APRV. So the examiner would be biased that yes, this candidate is excellent. And finally, you can conclude with, based on this waveform, I would adjust the settings to correct the underlying physiology, because it's always the physiology which is speaking on the monitor or screen. So that's why I have kept the quote. It's the patient who is talking, but as the tube is there, it is being relayed through the ventilator screen. And you, as intensivist, as the smart intensivist, you can understand what are the words the patient is trying to whisper. Clear? Now, I am just sharing with you some of the images. Just you can just go through. I know it is almost 3 hours, 30 minutes, and I am last. I would say in the cricket, I'm the last batsman waiting for my turn to be there. And I am going through all the lectures. So somehow I feel that you will be over bombarded with so much of information. So that's why I would be now sharing with you the pictures so that just have a visual impression printed in your mind. This is the square flow. Clear? This is volume control. Descending, volume control, flow. Okay. Identical flow wave, flow trigger is the pink. This means this is the flow trigger happening here. Decelerating, pressure control, flow. Variable deceleration, you can see the flow trigger here happening, pink. Now, this is the normal peak inspiratory flow. This is the decelerating flow, normal inspiratory time constant. Here happening reduced peak inspiratory flow. So there is some amount of resistance happening. Okay. Pressure control with decelerating flow, prolonged inspiratory time constant. Now, low compliance, you can see here, the delayed cycling, short inspiratory time constant. Here prolonged, here short. Clear? One is resistance problem, one is compliance problem. Then the inspiratory effort. The patient is trying to actually take so much of inspiration here. Upward shift of the inspiratory curve. Okay. It would look like a little bit of swollen. Now, these are the expiratory flow waveforms in volume control ventilation. You see here, normal expiratory line I have already told like this. If prolonged expiratory time, reduced expiratory flow is there, that means high resistance. If there would be low compliance in the flow, you see here, increased peak, expiratory short expiratory time here. Clear? Then it would be all in the baseline. Auto PEEP generated, I have already told you the flow, the inspiration begins before the expiration is complete. So that means every time there is air trapping. Okay. And that is actually affecting the venous return and the hemodynamics. Now, expiratory effort, you can see here expiratory flow moves downwards. I have shown you the inspiratory effort in the inspiratory waveform. That was a little bit swollen in the last picture. Now expiratory flow moves downward, it would be expiratory effort. Now inspiratory effort, you can see here, failed trigger. This patient is trying to trigger the ventilator, but it is unable to do it. Clear? Now expiratory flow limitation, I have already told it is taking so much of time to reach to the baseline here. Longer expiratory time. If you are getting tracheal secretions, you would get all these irregular oscillations. Okay, this is an excellent article. I would share with you the picture also. Now, coming to the few of the other things the examiner sometimes ask. This is the peak pressure, this is the plateau pressure, this is the PEEP. Now, high resistance, you would get the peak inspiratory pressure to be very high, but normal plateau pressure at the same level like normal. Okay, peak minus plateau is actually very high here. Okay, now low compliance, your plateau pressure is high, but your peak pressure is somehow okay. That means here resistance is not the problem, rather it would be the compliance is the problem. Here, high resistance, low compliance, it would look like this. Okay, now comes there would be a question, because I have been part of like some of these mock test as well as exams, where the examiner would be asking you what is SI, stress index. Now stress index, you have to sometimes draw it. The examiner would expect you what is the normal stress index. It is 0.9 to 1 or 0.95 to 1.05. If you are doing the recruitment, stress index would be less, upward concavity. Now over distension, it would be more than 1.05 over distension, downward concavity. And inspiratory effort, it would be downward concavity. Now, if the examiner would be expecting you to tell 2-3 lines about the ventilator stress index, VSI, what is this? This is the shape of the pressure time curve during volume control ventilation with constant flow. With constant flow, you can see here. Okay, flow would be constant, and you would be getting during the volume control ventilation pressure time. Now, what is the importance of the ventilator stress index? It guides your PEEP management, and again, what would be the tidal volume to prevent the VLI, ventilator induced lung injury. Normal is around 1. This would be linear rise. That means optimal compliance. Normal. Right. This is the normal, like this. Now, if it would be going up, upward concavity, that means less than 0.9. Recruitment, de-recruitment, you have to increase the PEEP. More than 1, downward concavity, that means over distension. That means you have to reduce the volume, tidal volume, or the PEEP. Clear? Okay. Now, this is something pressure waveform volume control and some of the other things that you need to remember. This is the resistance thing I have already told. Compliance thing I have already told. This is the expression with delayed cycle. It should be normally at this point, but it is taking a lot of time here. Cycle it. So volume control with descending flow. You can see here end inspiration is happening after like it should have been here. The pressure is increasing here. So that is not a good thing. You have to actually decrease the threshold for the cycling. Now, inspiratory effort, it would be like this. Cardiac oscillation, you will be getting this type of wave in the expiratory. So that is something will be affecting your the reverse triggering. So cardiac oscillation is one of the reason for the reverse triggering. Okay, early or reverse trigger. And there is a double trigger, that means no expiration is happening here. Patient is trying to breathe before the expiration is happening again. So you need to be troubleshoot the triggers. This is sometimes a favorite question, but yes, it need to be understood in the real context. Now, the ultimate memory frame for all of you, try to take it as a mental hook. MBIERACC. How you remember, I don't know, but this is something. Mode and the control, I have already told you. Baseline, inspiration, expiration, resistance versus compliance, asynchrony, clinical context, corrective action. If you remember this, nobody in this world can derail you. Just take my words. So I would be maybe at this is the last slide before I would be sharing with you maybe 2 articles. The distinction answer should be, the examiner would be standing with a standing ovation to all of you. The distinction answer, if you are answered this, this is worth gold. So give it a verbatim. Try to answer in this format. If the examiner expect you to tell in complete sentence, I analyze the ventilator graphics by first assessing patient interaction, identifying the mode and the control variable, naming the graphic, analyzing the baseline, inspiration, expression, differentiating resistance for the compliance, actively looking for asynchrony, correlating with the clinical context, and finally prioritizing corrective ventilator adjustment to address the underlying physiology. Oof. This is something the examiner would stand up and you will be like thinking that yes, you have got the gold medal. Now, common exam fail points. When you are talking about gold, you should also look at the coal. Okay, describing curves without naming the mode, ignoring expression, missing the basic things like auto pip, some of the standard maneuvers you are not knowing, you are not confident, low link to the patient comfort or the hemodynamics, and you have not discussed anything how you are going to have a corrective action. This is like something the examiner would not take 5 seconds to fail you. Okay. Now, these are the two articles I found very informative and conceptual building. One is the ventilator desynchrony narrative review. This was published in 2020 Annals of Thoracic Medicine. And this is the stepwise ventilator waveform assessment to diagnose pulmonary pathophysiology. This was published in Anesthesiology in July 2022. Now, at the end, if you are still not very sure, you are unable to troubleshoot your patient, and the examiner still expect you to solve the problem, try to enter into the ventilator, maybe using the hammer. If you don't have the hammer, take from the knee hammer from the bedside and try to enter. Thank you for your patient hearing, and I think we have crossed I think the time limit also. So if there would be any questions, I would be happy to answer. I hope the efforts that we have put are worth spending 3.5 hours in the, maybe I would say, the January last week of the 2026. And I hope that the lectures were up to mark. If you feel that there have been some technical glitches, this is completely beyond our capacity, and we all know this can happen with the real exam also. And this has been feedback from the edict 2 candidates also, that there have been some or other the hiccups. But at the end, everything that ends well is what we expect. Thank you very much. Though my troubleshooting ventilator is extensive one, I know I have one more lecture also where I was planning to discuss about the triggerings, the double triggering. But I think you all can go through the basic concept. In the examination, they would be expecting you to answer the basics. If you answer the basics, then definitely the gold is yours. Okay. Thank you very much. Good night. Take care. Please keep us posted for any of your needs. And as 360 Critical Care Academy, always we try to provide you out of the box lectures with global collaboration. And hopefully you will be also part of our all initiatives if you are interested in teaching to the fellow candidates. Thank you very much. Take care.